За мен е изключително удоволствие да открия втория семинар по програмата Европейски научни мрежи. Програмата се спонсорира от Министерството на образованието и нашия проект е свързан с проекта Transbrain, който всъщност включва и зрителният анализатор. Всички знаем, че пандемията от COVID-19 се отрази на офталмологичната практика, на медицинската грижа и въобще на живота ни като цяло. Въпросът е, че независимо от тези промени, ние трябва да бъдем в състояние да продължим с всички активности, с които се занимаваме, били те на чисто клиничното поприще или свързани с научна и учебна работа. За мен е огромно удоволствие да кажа, че днес към нас ще се включат и колегите от Италия и Германия. Първият лектор е колега от Италия, който от години се занимава с ретина. Ретината, както е казал професор Пашев, е мозък. И всъщност човек гледа с мозъка си, но ретината също притежава 3 неврона, т.е. на практика тя е единственото място в човешкото тяло, където рецептора се намира толкова близо до централната нервна система. Така че заболяванията на ретината са една почти интердисциплинарна област в офталмологията и от тази гледна точка е наистина изключително важно да обръщаме специално внимание на тази област. В България, за съжаление, има известно изоставане в лечението на ретиналните заболявания, особено когато става въпрос за хирургическо лечение. И по тази причина нашите гости днес ще ни запознаят с най-съвременните тенденции и възможности терапевтични за повлияване на ретиналните заболявания. Преди да започнем, разбира се, с техните презентации, ще направим един увод какво направи пандемията от COVID-19 с офталмологичната грижа и как ние можем да продължим. На всички вече ни е известно какво е COVID. Голяма част от нас преболедуваха или са вакцинирани, но така или иначе има много и различни симптоми. На фона на всичките тези симптоми, които добре познаваме, можем да кажем, че почти липсват доказателства за офталмологични увреждания. Разбира се, уврежданията, които нанесе пандемията от COVID-19 върху грижата за общото здраве е абсолютно непоправима и с това ние ще се борим години наред, може би не е песимистично да кажа и десетки години. Въпреки това, големия въпрос е има ли наистина потенциал за увреждане на очите при заразените от COVID. След справка на литературата, която направих за последните 16 месеца, мога да ви кажа, че резултатите са доста неубедителни. По-голямата част от публикациите са или кейс репорти, или кейс сирис, което означава, че това са 10 случая. Повечето хора не са абсолютно убедени, че това, което са наблюдавали, е наистина резултат от самата инфекция с COVID-19. На първо място конюнктивита, той е може би най-често спряганият проблем, свързан с COVID-19, като тук има една хипотеза, че след като се зарази конюнктивата с вируса, този вирус през носа може да попадне в носоглътката и оттам респективно да се разпространи. На базата на литературното проучване, конюнктивита е по-чест при така наречения британски вариант. При първия вариант на COVID-19 на практика конюнктивита се среща изключително рядко. Още по-рядко обаче се позитивира PCR, ако се вземе материал от конюнктивата. На практика от примерно 300 проби е позитивирана 1 или 2 проби, особено върху по-големите и мащабни проучвания, които са правени в Китай, което на практика означава, че нашата конюнктива вероятно има достатъчно добра защитна сила по отношение на вируса и всъщност трансконюнктивалното пренасене е по-скоро една хипотеза, отколкото реално. Инфектирането на слъзния вирус е другият много интересен момент. който много се дискутира. В началото настъпиха едни декларации: не носете контактни лещи, внимавайте как си изхвърляте контактните лещи, защото може да пренесете вируса на COVID-19 с контактните лещи. Всъщност се оказа, че до момента няма нито една контактна леща, в която с PCR, която е стояла дори в око на пациент, който е позитивен, т.е. PCR от гърления секрет на пациента е позитивен, а контактните му лещи са случайно с негативни изследвания. Така че инфектирането на слъзния филм отново е един момент, който подлежи на дискусия, като тук може да се спекулира, аз лично бих предпочела да го направя, че наличието на имуноглобулини и защитни фактори в слъзния филм отново имат протективно действие по отношение на вируса и това е причината, поради която PCR-ите са негативни. Както знаем, вируса уврежда малките съдове и се наблюдават при някои пациенти, които са с активна инфекция и в реконвалесцентния период микрохеморагии по муковидни екстудати. Аз лично имам пациенти, които са с микрохеморагии по муковидни екстудати. Парадоксално е, че те са млади хора. Даже имам дете, което е на 14 години, което рязко и внезапно съобщава на майка си, че е забелязало, че вижда някаква черна точка. Майката, понеже е като гледа и знае какво представляват черните точки, го доведе и то наистина беше с микрохеморагии в двете очи и с един-два помоковидни екстудата в лявото око. Като единственото обяснение за това беше предхождащата инфекция от COVID-19, тъй като детето беше боледувало около седмица и половина преди наличието на тези оплаквания. Миракулозно всичко изчезна и седмица след това очното дъно беше абсолютно чисто, но на практика, ако пациента няма субективни оплаквания, никой не скринира към момента очните дъна на пациенти след COVID-19, така че ние не можем да кажем дали това е често явление или е на практика казуистика. По отношение на промените с осици има няколко публикации вече върху осици промените и това, което се наблюдава е хиперрефлективни точки на нивото на ганглийния слой. Те не са описани почти при никаква друга патология и когато е правено масово изследване на пациенти след COVID-19, до 30% от пробите са позитивни за тези хиперрефлективни точки. Дали това се дължи директно на вирусно увреждане или се дължи на въздействието на някакви други фактори или се дължи на въздействието на хипоксията, която настъпва в резултат на увреждането на дихателната система, също не бихме могли да отговорим. И разбира се, един от така най-сериозните моменти, това са тромбозите, които се наблюдават при млади пациенти. Има описани вече случаи, те са доста на брой, даже има метаанализ на тези случаи, публикуван в литературата, за тромбоза при млади пациенти, която може да бъде както стволова, така и клон. Разбира се, потенциал от увреждане от COVID-19 е свързан с страха от заразяване и той е много по-голям, отколкото директните увреждания, защото пациенти с загуба на зрение наблюдаваме сравнително рядко, докато пациенти, които отказват лечението, забавят лечението, опитват се да преглътнат това, че качеството на зрението им е влошено, са наистина много. В литературата в момента така се надига една вълна от проблеми, които са при диабетици и особено лоша прогнозата на базата на статистиката, която е направена, е при пациентите с диабетен макулен едем. Вероятно при диабетици усложненията в резултат на инфекцията са свързани с съдовите промени, но не по-малко опасно е, когато диабетика в състояние на страх спре лечението си, ако е започнало вече такова лечение, или пропусне лечението си, или въобще пропусне да отиде на лекар при появата на първите симптоми. И се смята, че от социално значимите заболявания диабетния макулен едем е на практика номер 1 като увреждане. Какви са последствията? Ние все още трябва да се отговорим на въпроса какво се случи и какво да очакваме, защото бъдещето е в известен смисъл все още неизвестно. Персоналът трябва да се научи да работи при специални условия. Това безспорно е свързано с промяна на поведението, безспорно е свързано с промяна на общата култура, безспорно е свързано дори с поведението на обличане. Промени се общуването с нашите пациенти, аз ще се спра специално върху този момент. Разбирането на изолацията и интернет комуникацията станаха част от нашия живот, но това има, разбира се, и своите негативни последици. При всички положения трябва да спазваме условията на добра клинична практика и тя трябва да бъде модифицирана към настоящите условия. И не на последно място, всеки един лекар се явява лидер по отношение на персонала, с който работи. Имат се предвид медицински и разбира се, санитарите и останалия помощен персонал, но и лидер по отношение на пациентите и техните семейства. Така че тази лидерска позиция е особено важно да бъде запазена. В момента ние продължаваме да бъдем в една тежка епидемиологична обстановка, в която случаите продължават да нарастват. За вчерашния ден беше съобщен рекорден брой случаи на позитивни проби от направените общо проби за COVID-19, като това естествено е свързано с един престой. Престоят би трябвало да бъде активен, защото пасивният престой на практика ще донесе допълнителни както материални щети, така и щети свързани въобще с цялостната лечебна дейност. Така че реорганизацията в един такъв момент е особено важна. Офталмологията е трудна по принцип за уеб-базирани презентации, за уеб-базирани консултации, но в никакъв случай това не е невъзможно. И специално ние работим доста активно в създаването на платформа, която да ни позволи наистина да направим една платформа за уеб консултация. Разбира се, това е време, което би могло да бъде използвано за това да се промени организацията, да се направи почистване, ремонт, хората да се съберат и да вземат важни решения за промяната на организацията в тяхното лечебно заведение. Не на последно място биха могли да бъдат създадени нови информационни материали за пациентите, биха могли да бъдат създадени нови услуги и разбира се, това време би могло да бъде използвано за обучение на пациентите. Сега в този момент мисля, че е доста важно да ви запозная с едно проучване на Европейската асоциация по катаракта и рефрактивна хирургия, която прави много неща. И едно от тези позитивни неща е анкетата, която те направиха в началото на пандемията, която те повториха една година по-късно. И на базата на това се оказа, че голяма част от офталмолозите в европейски мащаб започват да използват все повече медиите, започват да използват все повече телефонните обаждания, видеоконсултациите с идеята да намалят постоперативните прегледи. Това, разбира се, при нашите условия малко трудно може да се осъществи, защото ние имаме задължителни постоперативни прегледи, които няма как да намалим, защото от една страна пациента си ги търси, от друга страна те са задължително изискване на Националната здравноосигурителна каса. Но, примерно, виждате, че в една Индия постоперативните прегледи са намалели с почти 40%, което означава, че се имплементират много бързо всички тези тенденции и изисквания на настоящата ситуация. По отношение на това какво се случва, ние работим в момента в условията на спешност. Това означава, че пациентите малко или много са изплашени. Съществува една тенденция да се мисли, че пациента се намира в състояние на повишена възможност за заразяване, ако дойде в болница. Вчера, например, се наложи да дойде куриер на DHL, който каза, ние в болници не влизаме, пратката трябва да бъде изнесена навън. Това е поведението и на нашите пациенти. Интернет в никакъв случай не е панацея, което означава, че физическото присъствие за голяма част от офталмологичните прегледи продължава да бъде наложително. И по тази причина, планирани или не, посещенията на нашите пациенти трябва да бъдат организирани във всяка една офталмологична практика. По отношение на забавянето на диагнозата и лечението, това нещо има отражение особено върху възрастните хора. В началото и преди ваксините възрастните хора бяха изключително изплашени. Аз лично имам много пациенти, които пропуснаха своите постоперативни визити. Това доведе до влошаване на техните проблеми, до това тези пациенти дори през летния период, когато нещата се поуспокоиха, да бъдат оплашени, подозрителни, да предпочитат да откажат лечение, вместо да продължат със своето лечение и поне да се опитаме да спасим това, което е останало. Естествено, това подозрение и този страх не е ограничен само до нашите пациенти. На практика нас също ни обхващат подобни настроения. Това е съвсем логично и съвсем нормално. И затова е изключително важно какво ще бъде посланието като цяло и индивидуалното послание на всеки конкретен лекар. По някакъв начин всеки трябва да намери своя щит, за да можем да се защитаваме от това, което ни се случва. Тъй или иначе най-големия страх е от заразяване, като възможностите за заразяване в едно лечебно заведение са като в една банка, на практика между служителите и пациентите, както пациентите могат да предадат на пациенти инфекцията, така и служители могат да я предадат на служители и респективно между пациенти и служители също може да стане подобен ефект. Проблема е, че нямаме гаранция, че това нещо се случва точно при конкретните условия, защото аз имах разговор с лекар, който беше сметнал, че е заразен в лечебното заведение, в което работи. И всъщност се оказа, че освен изпълнявайки своите трудови задължения, той е вземал детето си от детска градина, контактувал е с съпруга си, който също работи в колектив, пътувал е с автобус, посещавал е магазин и на практика няма по какъв начин наистина да се докаже този епидемиологичен път на заразяването, което още повече създава един безумен страх. В обучението, което е свързано с контактите с пациентите, ние винаги се опитваме да покажем близост и това понякога отнема изключително много време, докато бъде обучен един служител към подобно поведение. Същото нещо се отнася и по отношение на самия колектив. За съжаление, в момента на мода са преградите от плексиглас, които виждаме навсякъде, които се налага да бъдат поставени между пациентите и лекуващите лекари. Знаете, че ние също имаме прегради на биомикроскопите. И тук отново искам да се обърна към проучването на Асоциацията по катаракта и рефрактивна хирургия, като там един от въпросите, въпрос номер 10, който те задават, е какви са мерките, които те са взели, за да протектират своите служители. Тоест, всеки, който има офталмологична практика, какво е направил с цел да протектира служителите. Виждаме, че най-популярната мярка е намаление на работните часове и разделянето на хората на екипи, за да може да се намали контакта между тях и респективно да се намали възможността за зараза. Самоизолацията е също една такава възможност, използването на отпуски и така нататък. Промени се и нашата култура на поведение. Сега никой не му е приятно да види джипито си в такъв вид. Аз лично моето джипи редовно го виждам в такъв вид, с защитни очила, 2 маски, шапка на главата и защитен костюм. Но това са условията, в които работим. Едно е важно, в миналото всички си позволявахме да избираме начина на обличане. Днес бялата престилка е като че ли един добър вариант, защото тя създава някаква сигурност и спокойствие в пациента. Неща от типа на прибраната коса, маски за еднократна употреба, някакъв щит или биоптични очила или очила приличащи на биоптични. Намаляване на броя на бижутата, къси ногти без лак, специални обувки за закрито. Това са съвсем елементарни неща, които обаче в последствие се наложиха като един стандарт, който създава сигурност в нашите пациенти. Съвсем логично е, че една сестра на висок ток прави по-добро емоционално впечатление, но в конкретната ситуация това не е точно така. По отношение на средата, да, разбира се, защитните прегради са една възможност. Обмяната на документите трябва да бъде редуцирана. Независимо от опитите, които правим, все още електронните досиета не са въведени, което на практика означава, че ние имаме директен физически контакт. Дезинфекцията след всеки пациент е абсолютно задължителна, като в миналото идеята беше колко може повече хора да се занимават с един пациент, за да може той наистина да има един положителен опит от взаимоотношението, при настоящите условия най-добре конкретно лице да извърши всички изследвания на пациента, за да може да се редуцират контактите и това до някъде, бих казала, дори усъкътява нашата клинична практика. По отношение на Асоциацията за катарактална и рефрактивна хирургия и нейния въпрос номер 14, каква е персоналната защита, която те препоръчват? Се вижда, че хирургическата маска е една от възможностите, заедно с протекцията на очите с помощта на специални очила, като специалните маски не се употребяват толкова масово. Аз мога да ви кажа, че вчера ми се наложи да нося специална маска и това нещо доведе до въпроси поне от 5 човека дали не съм болна случайно, защото маската наистина, която е с пълна херметичност и с филтър, нарушава много сериозно дихателните функции. И човек наистина първо не може да говори нормално, второ не се чувства съвсем добре, защото усеща едно ограничаване на въздушния поток. Така че това променя цялостното поведение на човека и това е причината, поради която, както виждате, тези маски продължават да не бъдат особено популярни и да се използват обичайните хирургически маски вместо специалните маски. Използването на шилдове за лице също е така дискутабилно и обект на дебат. Аз лично не виждам защо трябва да бъде използван шилд само пред устата, защото така или иначе това, което излиза, то се насочва в посока към останалите хора, които се намират в стаята и според мен протекцията там така или иначе не е достатъчно добра. Но тук е момента да кажа, че в последно време наблюдавам много упражнения от носенето на маски. Първо зачестиха бактериалните пневмонии и те са доста по-често при пациентите, които им се налагат да бъдат през целия ден с маска. Тоест хората, които работят от така наречения home office, сравнително рядко правят конюнктивити в момента, докато хората, които им се налагат цял ден да бъдат с маска, правят конюнктивити. Второто, като че ли усложнение от маската, са травмите, особено маските, които имат твърда част, която да се закрепя на носа, или в страни краищата, които имам поне 10 пациента, които са с хеморагия от крайчето на маската, като от тези 10, само 3 или 4 мятат, че това се е случило благодарение на маската, останалите дори не са забелязали кога се е случило, но те са много типични в латералния точен ъгъл и на практика биха могли да бъдат разпознати. По отношение на персоналната хигиена, безспорно офталмологията налага изключително добра персонална хигиена. В случаите, в които имаме някакви рискови пациенти, независимо дали от COVID-19 или някакви други рискови пациенти, е задължително да използваме ръкавици без тал. Но тогава, когато използваме ръцете си, те естествено трябва да бъдат дезинфекцирани, трябва да се обърне особено внимание на дезинфекцията на оборудването. Всички знаете, че ние разпространихме тези щити в цяла България и в момента хората, нашите колеги в България все още продължават да се възползват от това. Не бива да ни убягва психологическия тормоз, който цялата пандемия оказа върху всеки един от нас. Несигурност, неувереност, притесненост, претовареност, дори страх и депресия са възможностите, които могат да стъпят в резултат на въздействието и на социалното въздействие на пандемията върху всеки един служител, независимо от неговата позиция, независимо дали е санитар или е лекар. Тази несигурност се засилва от цялата ситуация, защото ние в момента наистина не знаем какво ще се случи. Наистина не знаем по какъв начин да реагираме. Има много необичайни ситуации, има много нови ситуации. И в зависимост от психологическата стабилност на всеки един конкретен човек, това може да доведе до различни промени, някои от които могат да бъдат и по-сериозни. За съжаление, официалната статистика показва, че се увеличава броя на хората с депресии, както и на хората, които предприемат самоубийство или на практика успешни в този слой. Ето защо работата в екип е изключително важна. Друг много важен момент са практическите правила. Те трябва да бъдат свързани с пациента, служителите, апаратурата, процедурата и всичко да бъде съгласно общите правила. Защото общите правила на практика са базирани на целия световен опит. Това не означава, че в офталмологията не трябва да има специфични правила. Много е важен момент правилата, които са свързани с пациента и с служителите, да не се разминават, защото ако примерно за пациента е важно да носи маска, за служителя не е или обратното, това създава двоен стандарт, което е изключително неприятно. Това е въпрос номер 13 от въпросника на Асоциацията по катарактална и рефрактивна хирургия. И въпросът е какви са превентивните мерки, които използват пациентите. Голяма част от пациентите свикнаха да мият и дезинфекцират ръцете си, даже някои пациенти си търсят дезинфектант, така че ако в началото хората се притесняваха от това да ползват дезинфектант, сега в известен смисъл всеки един от тях търси дезинфектанта преди да влезе или да излезе от лечебното заведение. Повечето хора вече се научиха да носят хирургически маски. Това са двете най-използвани мерки, заедно с физическата дистанция. Носенето на ръкавици се наложи след някои следи, но в интерес на истината много малка част и в Европа хората използват ръкавици, защото ръкавиците в известен смисъл са рискови сами по себе си, освен че могат да променят кожата на ръцете и след като се свалят да бъдат до някакъв проблем. Сами по себе си те като че ли създават едно фалшиво усещане за защита, но в същото време, ако са тези част на лицето, риска от зараза е много по-голям. По отношение на правилата, свързани с пациентите, пациентите трябва да бъдат задължително информирани, особено когато става въпрос за малки пациенти. Добре е това да бъде поставено като правила в интернет, те да са ясни, да бъдат добре демонстрирани и от персонала, защото отново повтарям, че ако персонала нарушава правилата, няма как това да бъде изискано от нашите пациенти. За съжаление, това е свързано с икономически последици, защото след като се създадат правила, трябва да се създадат условия за тяхното спазване. Тоест, това е свързано с закупуването на допълнително количество маски, допълнително количество допълнително обучение на различни нива в съответните екипи. И това, което е интересно отново от проучването на катаракта и рефрактивна хирургия, това е по отношение на какви мерки са взели съответните практики и по какъв начин хората са показали удовлетвореност от взетите мерки. Вижда се, че около 50% от хората са горе-долу удовлетворени, останалата част от хората обаче не са особено удовлетворени. Тук е може би момента да изкоментирам, че това не са само мерките. Тази неудовлетвореност, която хората демонстрират в анкетата, е най-вече резултат от това, че като цяло ситуацията е изключително депресираща, тежка за понасяне и негативите се пренасят върху всеки един въпрос, с който ние се срещаме в нашия живот. По отношение на конкретните неща, които са свързани с нашата пряка работа, дезинфекцията на рампите и фуроптера след всеки пациент е задължително. За биомикроскопа въобще не става въпрос. На практика не е подходящо пациента да бъде поставен на биомикроскоп, без дори да му бъде демонстрирано, че този микроскоп се дезинфекцира. Можем да варираме в технологията. Типичен пример в това отношение е избягването на директната офталмоскопия. Това, което направихме в Света Марина, използването на камера с цел да няма директен контакт и да може снимката да бъде взета от хората, които така или иначе се намират в хората отделение. По отношение на контактните лещи, или те диагностични или терапевтични, лещите за еднократна употреба определено са добър вариант, но не винаги може да се употребим. И разбира се, всеки един пациент трябва да премине нужното обучение, за да можем да сме сигурни, че това, което правим, ще бъде продуктивно за цялостната ситуация. Когато споменах думата контактни лещи и контактни лещи с оптична цел, бих искала да кажа, че аз не забранявам на моите пациенти да носят контактни лещи. Контактните лещи при голяма част от пациентите осигуряват качество на живот. Това е свързано с много психологически моменти. Тук е мястото да подчертая, че един пациент, който носи контактни лещи, е на практика най-добре обучения на хигиена на очите пациент, който имате във вашата практика. Защото ние отделяме внимание на всеки пациент и всеки един пациент, който носи контактни лещи, е преминал обучение. Така че на тези пациенти наистина може да се разчита. Обикновените очила така или иначе не предпазват в повечето случаи. Освен това говорихме, че защитата на предната очна повърхност е достатъчно добра. Така че ако пациента желая да носи контактни лещи, а част от пациентите в момента отново заради маските желаят да го направят, тъй като замъгляването на очилата от маската е много неприятно явление. Така че те имат горе-долу два варианта: да се извадят носа или да носят маски и контактни лещи. Аз лично не ги спирам от това им желание. Другия голям въпрос, освен да нося контактни лещи или не, е да оперираме или не. В началото много се говореше за така наречената високоскоростна апаратура. Това са основно витреотомите, при които се получава един зол, който пациентът би могъл да не пациентът, би могъл да излезе от окото. И подобно на това, което се издишва от пациента при под обща анестезия, да попадне в очите на хирурга. 3D технологията в известен смисъл ни предпазва от подобно явление, тъй като ние се намираме далеч от оперативното и на практика наблюдаваме в изправяне състояние. Като 3D технологията ни позволява да поставим включително и шлема, ако искаме да така или иначе имаме пациенти, които имат усложнения и малко или много е задължително тези пациенти да бъдат оперирани. По отношение на хирургичната специфика, тук мога да кажа, че при всеки следващ локдаун трансплантациите продължават да бъдат разрешени. Възниква въпроса: ние искаме ли да правим трансплантации в условията на локдаун? Аз лично имам резерви по няколко причини. Първо, трансплантираните пациенти трябва да спазват определен режим на посещение, който е доста често, особено в началото. Носейки страха от зараза, тези пациенти гледат да пропускат някои от визитите си, което по никакъв начин не се отразява благоприятно върху тях. Второто нещо, което е, ако наистина пациентът се зарази с инфекцията и той е току-що трансплантиран, ние не знаем какво се случи с тази трансплантация. Така че, освен ако не е трансплантация по спешност или трансплантация с цел да запази окото, или трансплантация на амниотична мембрана, според мен чистата робочна трансплантация носи повишен риск. По отношение на това по какъв начин можем да използваме медиите, за да подкрепим нашите пациенти, разбира се, ние започнахме много повече да говорим с тях по телефона. Те и се научиха да осъществяват телефонни консултации. Един добър вариант е да имаме гласова почта в извънработно време с опити да препращаме пациентите по мейли. Разбира се, не всички пациенти се справят с тези неща. Трябва да се съобразим с факта, че част от нашите пациенти са много възрастни, друга част са слабо зрящи. И тук може би телемедицинските консултации с участието на млади близки на пациента биха били от голямо значение. Не на последно място е така наречената реципрочност. Всички знаем какво се случи в началото, всички ни призоваваха да се стоим вкъщи, за да могат те да работят нормално. Това нещо беше един призив, който се прие изключително добре. Но реципрочност трябва да има във всяко поведение от носенето на маската до измиването на ръцете преди да прегледаме следващия пациент с вербално подчертаване на този процес, защото пациентите са с повишено внимание и един малък пропуск от нашата страна може да се отрази негативно по отношение на това какво ще бъде поведението на пациента. За съжаление, пандемията може да доведе до много негативни последствия от типа на това пациента да е забравил за своя очен проблем, да е решил, че очният проблем е пренебрежим, да бъде посъветван да не ходи на очен лекар, защото с очите няма кой знае какво да стане, но с общото му състояние може да се случи нещо. И нека не забравяме, че пандемията има икономически последици, особено за някои пациенти, които наистина останаха без работа и без възможности да обърнат внимание на своите очи, да сменят оптичната си корекция, да направят регулярния си преглед, да сменят контактните си лещи, например, да използват нужните разтвори и тези икономии, които пациентите си налагат, всъщност могат да доведат до допълнителни усложнения, на които трябва да обръщаме внимание. В една такава деликатна ситуация един от важните психологически моменти е да не се опитваме да вменяваме вина на пациентите. Да, пристигат пациенти с усложнения, но не трябва допълнително да ги натоварваме психологически. Казваме им, да, ако бяхте дошли преди 2 месеца, нещата нямаше да изглеждат по този начин или много сте закъснял, защото сте стоял вкъщи. Пациентът трябва да получи информация, че процеса е напреднал. Но в никакъв случай това не трябва да бъде свързано с вменяването на вина, особено когато става въпрос за родители, защото родителите са много чувствителни и понякога дори да не им вменим вина, те започват да се чувстват много. Всъщност, пандемията има и позитивни страни. Една такава позитивна страна е факта, че хората са изолирани и са изолирани от всякакви контакти. Те са склонни да експериментират, склонни са да опитат нещо ново. В това отношение бихме могли да им предложим алтернативни варианти. Типичен пример е носенето на контактни лещи през очила. Но трябва да се съобразим с това, че в деликатно психологическо състояние тези пациенти могат да вземат и грешни решения. Така че трябва да бъдем изключително гъвкави и наистина да прилагаме всички правила на персоналната медицина. Тук искам да обърна внимание върху икономическата ситуация. Това, между другото, е графиката на Рей Далио. И тя показва, че винаги след някакъв върхов момент в икономиката имаме една дълбока бръзда, като това нещо се наслагва от една допълнителна осцилация на икономиката през цялото време. Според мен ние в момента се намираме някъде в долната част на тази крива и тепърва предстои да дойдем в тази много дълбока част и това се дължи на факта, че в икономическо отношение доста сериозно напредна кризата, доста сериозно напреднаха процесите, които са свързани с компенсации и малко или много в някакъв момент ще трябва да платим за този престой и ще трябва да платим за компенсацията, която ни беше предоставена. Така че разбирането на икономиката и разбирането на икономическата ситуация за медицината е от особено значение, като един от добрите варианти е извършването на слот анализ. Преди малко споменах, че лидерството по време на пандемия е много важно. Да, то е важно, защото всеки един от нас, бидейки лекар, бидейки медицинска сестра, той в един момент се превръща в лидер. Намира се в една среда с предизвикателства, където има наистина много неизвестни и той трябва да успее да постави на първо място интересите на пациента и след това да развие всички останали сюжетни линии, които се налагат. Един голям проблем в условията на пандемия са разходите, защото аз гледах икономическите показатели на Global за 2020 година и мога да ви кажа, че разходите категорично са се увеличили с около 40%. При това приходите на фона на тези разходи са намалени. Резерви в едни такива условия естествено не могат да се осигурят, което означава, че това уврежда цялата политика за капиталови инвестиции и за вложения. И естествено това има негативни последици в дългосрочен план. Затова и това, което преди малко показах на графиката на Рей Далило, на практика се очаква ние да изпитаме резултатите от кризата след следващата година, т.е. 2021 година. Въпреки всичко, ние трябва да продължим, трябва да създадем максимално защитена среда, да бъдем загрижени за себе си, за здравето на колегите си, за нашите пациенти, да използваме електронната среда, когато това е разумно, но не трябва да забравяме, че истинския преглед е с по-висока стойност, така че трябва да се опитаме да я запазим. Да се ориентираме към по-малко излишъци в краткосрочен план, въпреки че надали това е абсолютно. Времето, разбира се, е инвестиция. Загубата на време е най-голямата загуба в един човешки живот, защото времето е безценно за нас. Независимо колко се промени света, пациентите трябва да виждат, те искат да виждат и ние сме хората, които можем да им осигуряваме условия да виждат. Така че трябва да работим за запазване на зрителните нужди на нашите пациенти. Не трябва да забравяме за реципрочността. Знаете много добре, че всеки един пациент винаги пита защо вие носите очила, пък на мен ми давате контактни вещи. И се успокоява тогава, когато ви обясним, че ние също носим контактни вещи, но в определени ситуации. Днес може би е толкова важно да бъдем добри офталмолози, колкото и добри психолози, защото пандемията ни поставя в условията на нови преживявания, на нови проблеми и ние трябва да се опитваме да се справяме паралелно с тях. Разбира се, много е трудно да се справим с една такава ситуация, затова е необходимо не само да бъдем лидери, но и да работим в консорциум, т.е. да работим заедно с доверие помежду. И разбира се, една разумна инвестиция би била добре дошла, особено ако това е свързано с инвестиция, която идва с някакви допълнителни средства извън тези, които ни се предоставят от Националната здравноосигурителна каса. С това смятам да приключа с това въведение и ако има някакви въпроси, съм готова да отговоря. Те могат да бъдат задавани писмено. Това всъщност важи и за въпросите, които могат да бъдат задавани към нашите гости. Въпросите към нашите гости могат да бъдат задавани в писмен вариант през чата, за да може да ги оценим. Може да ги задавате както на български, така и на английски език, както на вас ви е удобно. Така, колеги, ако нямате въпроси, ще се видим точно в 12:25 българско време, когато ще поканим нашия гост Марио от Италия, който ще изнесе две много интересни презентации. Поне за мен смятам, че това ще бъде високотехнологична и интересна практика, в която той има опит. Той, между другото, има опит и в микроскопията, така че можем да му задаваме въпроси в тази посока. За сега ви благодаря за вниманието.
How are you?
I'm fine. How are you?
How are you?
It looks like we're going to see each other more often than
and then in meetings. Yeah.
Great.
So how are you? Fine. The situation is. I'm working in Bergamo. That is the place where the COVID started, and so now it's still not easy, and so. Let's hope that the vaccine will end up soon with good results, because we are still under pressure here in the hospital.
Yeah. This is I'm sure you had a very hard time. So the situation in Germany actually is quite okay. And as our eye hospital is kind of separate to the rest of the university, to be honest, we didn't have any case of infection in our clinic.
Great.
We had a few patients, of course, who had been COVID-19 positive, but meanwhile, everybody is vaccinated. So it's
in my department, by the end of March last year, 80% were positive of a doctor that are working with me. So we are 21, 80% positive, and one was already died by the end of March.
No.
Last year, yeah. So it was very strong, here.
And do you know the reason why so many doctors died? Because
at the beginning they didn't realize, and they think it was running since probably a few months before, and and they were starting, they were doing, clinics, everything, and without any, precaution. So
okay.
Anyway.
Tough time. Yeah, so I hope the thing is, it's nowadays it's going for such a long time, and the people get tired of all the regulations. This is what I'm actually afraid of.
Okay, so we need to start in 20 minutes, right?
I'm actually okay. So I'm just very early. That's good because I should finish my.
Okay, good. I think I have my presentation in 20 minutes according to the schedule that was sent to me. So 11:30, I have my presentation.
Okay, because I was a little bit scared. I just elongated it because I thought that I had to talk 1 hour and a half.
Me too. And I think they sent us yesterday the schedule, and I saw that they were scheduled at 11:30.
And I'm expected to start it at 1 p.m.
Yeah, you will be at 1 p.m. Yeah. Okay. So let's finish our presentation.
Let's finish our slide. We'll see each other in a minute. Bye.
Ciao, Mario. Welcome.
Hello.
Hello.
How are you?
Fine, thank you. And you?
Very well. Very well. So, we are. I'm working between Bergamo and Milan, and in the situation is not so easy still, and and so we have the hospital full of COVID patients, and but we are working. At least we are now in another place, not in the COVID center, so we are still running with the theaters and with the clinics. So
okay, so sounds okay, because we heard lots about Bergamo on the news.
Yeah. And last year, this time we were. I remember in my department we are 21. 80% were COVID positive, and one was already died by the end of March. Between ophthalmologists,
Yeah, that's scary, really. But hopefully everything goes. But I guess that you have vaccinations as well, most of the stuff anyway.
Yeah, so now it's much better, of course, but still we are in time. We are hoping for vaccine, to run fast.
Hello, Siegfried.
Hi, Christina. I just have to, sorry, just have to answer your phone call.
Yeah, that's fine, no problem.
So I will go for the two presentations, right?
Yes.
Okay. What do you like more? So I can stop whenever you like, or we can discuss by the end of presentation, probably by the end of each one.
Yeah, I guess that I'm going to introduce you in a second, and after that we are going to do your first presentation, give it a little bit of time for questions, and then we go with the second presentation.
Okay. So how long you like to be the presentation?
We have time planned until 1 o'clock, so 45
Okay.
minutes per presentation.
Okay, so let's try to finish a little bit early each one to give a bit of discussion, right?
Yes, yeah, like
Okay.
finish like in 40 minutes, and then if we are a little bit late, I'm sure Siegfried is
Okay.
not going to kill us, because after you is just Siegfried. So yeah,
And
it's
and what about the audience? They are a resident, they are ophthalmologists.
it's a combination. There are young ophthalmologists who are already with specialty in ophthalmology and are interested in vitreoretinal surgery. And also there are residents as well, of course, because they're always invited to events like this. But we are just trying to outline the first steps when you are starting vitreoretinal surgery in the department. What you should do. So this is the accent. The accent is what the beginner should not miss, and what is the compulsory thing that they should do. And then, as I mentioned before, if you are happy, whenever we have possibility to fly people around, we can invite you.
Okay.
Because,
Okay.
we have the 3D
Thank
technology.
you.
We have the 3D technology here, and we can arrange. I hope that it will be relatively okay to fly in 2 months or so, but nobody knows really.
Yeah. Okay. So thank you very much, and congratulations for the initiative for managing all these things together. So very good.
Yeah, well, the problem is that at the moment everything is in the hands of the companies, as always. And when you're presenting for a company, you're always biased. You have to be careful not to say this, not to say that. So we decided that we do it via the university. So when we are doing it via the university, is not biased. So you can be absolutely fair in your hands, what is working, how it's working. If something needs a critique, you're absolutely free to give the critique. If something needs an appraisal, it's absolutely okay to give an appraisal. So we have 2 more minutes, and then I'm going to introduce Mario first, and then afterwards we are going to have Professor Pliglinger as well.
Christina, may I ask you a question? Because I was a little bit concerned yesterday. Just made a few more slides. Am I expected? How long I am expected to talk? Because
about hour and a half altogether. But if you need more time, it's okay. If you need less time, it's okay.
I don't need so much time. Okay.
Okay. So not a problem at all. We are pretty flexible. Everything is online. We are not paying for the venue. So it's fine. And if somebody really needs to leave, you know that with WebEx it's so easy that it changed our life completely.
And we're going to discuss the different sections of the talk, or am I expected to talk the whole time?
We can stop and discuss. We just arranged with Mario that he stops in the middle, and we make the first discussion in the middle, and after that do the second discussion at the end.
Okay.
So it's absolutely up to you.
Is it students or ophthalmologists?
Excuse me?
Is it students?
No. They are young specialists who are starting vitreoretinal surgery and residents who are quite in advanced stage. So no, maybe there is 1 or 2 very advanced students that want to hear, but audience is doctors. So.
Great.
Okay, so it's 12:30, and it's my pleasure to open the second part of this seminar today. And it's my pleasure that Mario Romano agreed to join us. Mario Romano comes from Italy. Actually, he works between Bergamo and also Milan. Of course, this is a hot area at the moment because of the problem. Mario is specialized in vitreoretinal surgery. Actually, he is director of these services at eye department at Humanitas Bergamo, and also he is associated professor of ophthalmology at University of Milan. Mario had specialties, the first one in UK, in Liverpool, and the second one in Boston, which is actually quite interesting because our second lecturer, Professor Friedlinger, also had his fellowship in Boston. So somehow we are having a bias to Boston today. And I would also like to mention something about Mario. Mario is very keen in marathons. Siegfried is a marathon runner as well, I know. But for Mario, I would like to mention something very special. Mario actually did the Ironman, which is quite impressive. So I'm giving the word to the Ironman in vitreoretinal surgery. Mario, the floor is yours.
Thank you so much for a kind invitation. This is the first time that I was introduced, on Ironman, and so thank you so much. This is make me very happy because it's something that nobody knows. I don't know how did you get, probably on the my website. I don't know, but thank you so much. And I'm sorry that we cannot speak about the Ironman because probably is also a good topic, but I will share my presentation on the first one on the diagnosis and treatment of idiopathic and diabetic epiretinal membranes. So, just a second, I wanna. Okay. So, I have in the middle. Okay. So, surgical timing is one of the most relevant prognostic factor. And we know that patients with better initial visual acuity and low degree of preoperative metamorphopsia have a better prognosis. The point is, if we are thinking of operating patients with good visual acuity, we need to also to keep in mind on the other side that 20% of the eyes, only 20% will require surgery after 4 years, according to this Kaplan-Meier. So the point is we need to know when we should operate, and this is not an easy topic. And so at the end of presentation, we can discuss together. So basically, we are looking now for morphological parameters in additional, of course, to functional parameters. We recently published a paper looking to the intraretinal changes in idiopathic epiretinal membrane and diabetic epiretinal membrane. So we are now bringing our attention from the interface, Vitroidan Interface, to the intraretinal changes in presence of an epiretinal membrane. And we will find that the features are different, and also the biomarker that we need to look at in order to plan the surgery are different in idiopathic versus diabetic patients. So we can tell to the patient that in both cases we have an edema. But as you can see, the edema in idiopathic one is completely different from the edema in the diabetic one. In both of them, there is a traction, okay? So the biomarkers, as you can see, and we will go in details, are different between idiopathic and diabetic. So this is the reason why we want to better understand which one we need to look at to plan the surgery. And moving from the interface to the intraretinal changes, we need to keep in mind that in the retina we have 6 major classes of neurons, but one single type of glial cells, the Macular glial cells, going from the inner to the external limiting membrane. And Mueller cells, together with astrocytes, are the macroglia, so responsible for neuronal structural support to the cells, connection elements between the neurons and the vascular cells, and they also contribute to the local inflammatory response through the microglia. So the functional impairment is not just a matter of physical traction, but also intraretinal reactive gliosis. So in presence of an epiretinal membrane, the Mueller cells react, increasing the GFAP. So now we want to have a look to the macroglia changes, also to helping us to better understand the pathogenesis. So to differentiate a tractional form, for the tractional form, of course, we need the surgery, the exudative form, and the mixed form. So because according to the pathogenesis, we need to do the surgery or we need to do injections, or we need to do something that is in between, and we will see later. So regarding the pathogenesis, how can we differentiate the tractional from exudative from mixed form according to the intraretinal changes? Because if we have a look just to the epiretinal changes, we can see just a membrane. We need to look inside the retina. So we recently published this paper. Is a mathematical model of force transmission on the Mueller cells with the help of engineer and of course with the histology. We know that the Mueller cells are straight in the middle in the foveola, and then they have going out from the foveola going towards the periphery, they have this Zeta-shaped morphology. And in relaxed configuration, so the Zeta-shaped morphology, the Mueller cells have the horizontal process, the one that we call R2. The horizontal process are in between the outer nuclear layer and the outer plexiform layer, so in the Allen fiber layer. And the horizontal process are responsible for the damping effect. So what does it mean? That when we have traction, this angle is not of 90 degrees anymore, but will be in between 0 and 90 degrees, like in tractional lamellar macular hole. And in myopic eye, as you can see here, are straight, so the angle is 0. So the damping effect is very important because the Mueller cells have also another function as optic fiber. So even sometimes in this kind of patient, the patient can still see very well because the Mueller cells are still working well. The point is when there is some gliosis in between and the patient cannot see well anymore, and so it's not just a matter of metamorphopsia, but is also a matter of quality of vision and dispersion of light. But let's go step by step. So such changes in the morphology of Mueller cells under traction help to differentiate the tractional form from the exudative form. And we published another paper looking at the difference in morphology according to the intraretinal fluid accumulation in exudative and in tractional form. And in this paper, we had a look in a retrospective analysis, 72 eyes, and we had a look at the intraretinal cystoid spaces on ANFAS in exudative and tractional disorders. And what we found that the morphology of distribution of fluid is different, and it an indication for differential diagnosis. So let's have a look. In the exudative form at ANFAS OCT, at the level of outer nuclear layer, we have this cystoid space. They have a petaloid pattern. Whereas in a tractional form, we have cystoid spaces in a spoke wheel radial pattern. So the morphology is different because different is the health of the Mueller cells. In this case, we will see that the Mueller cells, like in exudative diabetic patient, are going for apoptosis, whereas in tractional forms, the Mueller cells are still there, but it's just a displacement. This is the reason why the accumulation of fluid is different. So in exudative form, we have this petaloid pattern, and we have damage of inner and outer retinal barrier with increase in thickness of inner nuclear layer. Whereas in tractional form, we have not a big damage of retinal barrier, and we have a normal thickness of inner nuclear layer, and the Mueller cells are just displaced by the traction. If you have a look in this slide, we have a patient that has a mixed form, have an exudation, okay, but at the same time has an epiretinal membrane on it. We did the injection, and you can see at the unfast OCT, there are, the petaloid pattern, but also the spoke wheel pattern. After the injection, you can see there is not this exudative pattern anymore here, and you can still see the tractional pattern that's here. So this is evidence of the difference between exudative and tractional, and how we need to treat in a different way the two entities. Timing of the surgery. This is another important point because if we know that it's a tractional form, then we need to think when we need to do the surgery. Okay, and according to the paper that I was telling you before, the traction is, the visual impairment is related also to the tractional forces. So when the traction is too strong, we will start to have an increased GFP in between, an increase of gliosis in between. We will see better in the next few slides. So this is the timeline of our research. When we have an epiretinal membrane, we start to see some increase of thickness in the ganglion cell complex. So in the first 90 micron from the inner limiting membrane. Then Andrea Govetto published that you can start seeing a gliosis in this ganglion cell complex, and this continuous ectopic inner foveal layer is correlated to the visual acuity. So if increased in intraretinal gliosis, you will have less, the patient will see less, but also will have less recovery if the gliosis is too big. So this is one of our biomarker. We published then that there is a correlation of this inner retinal gliosis and the expression of GFP. GFP is an intermediate filament of the Mueller cells. So under traction, the Mueller cells start to increase the GFP. And then in the last paper that I was speaking on, we found that in the diabetic one, we have not the intraretinal gliosis, but we have another biomarker that I'll tell you later. So in idiopathic epiretinal membrane, under traction, the macroglia is activated, and so the Mueller cells are activated, and the aim is to produce gliosis in order to protect the nervous tissue. Okay, and so GFP is produced by the Mueller cells and by the astrocytes, so the macroglia, and are localized in the fovea, but are localized at the posterior pole mainly, and so you can find, especially the astrocytes, so this is the reason why we can see this glial tissue at posterior pole more than in periphery. So there is a difference, as I was telling you before. I don't know why it's running. Telling you before that there is a difference in intraretinal changes in idiopathic versus diabetic. And in this paper, we found that in idiopathic one, you have this gliosis. In diabetic one, you have the formation of intraretinal cyst and an enlargement of capillary free zone of deep vascular plexus. If you do the surgery, you have a shortening of the gliosis after the peeling in idiopathic one. But after the peeling in the diabetic one, you have the release of traction, reduction of intraretinal cyst. But you have also an increase of capillary free zone of deep vascular plexus. So this is important because we need to know that our surgery will induce also iatrogenic damage, especially in diabetic patients. And when we do the peeling in a diabetic patient, we will increase the damage of the Mueller cells. And we know that the Mueller cells are already damaged by the disease, and if we do the peeling, we will induce a further damage. So in idiopathic epiretinal membrane, you have the increase of GFAP gliosis. In diabetic epiretinal membrane, you have the formation of intraretinal cyst. So in idiopathic one, the Mueller cells are healthy. In the diabetic one, the Mueller cells are weak. When we do the peeling, we need to keep in mind that doing the ILM peeling, we can induce a further damage to the Mueller cells. So at the end, we need to do the surgery when the cysts in diabetic one are not so big, and when we have not just already an enlargement of capillary free zone of deep vascular plexus at angio-OCT. So again, in idiopathic one, we need to have a look the first 90 micron ganglion cell complex thickness, because are a biomarker for intraretinal changes in presence of epiretinal membrane. Have a look at these slides. This is a wrinkling just at the beginning of the traction, and then you have an enlargement of outer nuclear layer, but there is nothing in between. It's not still gliosis, not yet gliosis, and then you start to see gliosis under the ILM, and in this case, the patient will start to see less, and then the gliosis will increase, and with damage with intraretinal changes. So, I mean, we cannot weigh the damage of outer nuclear layer, because the first damage is in inner layers, not in outer retinal layers. So if you see, there is a classification in 4 stages. And this is stage 2, where we have an enlargement of outer nuclear layer. And in stage 3, you start to see these continuous hyperreflective bands here, and that is in between the inner nuclear layer and inner plexiform layer. And the stage 3 again, you can see there is this ectopic hyperreflective layer that is in between. And then in stage 4 will increase more. So we need to do the surgery when we are in at the beginning of stage 3. Stage 2, the patient can still see very well. And then the progression from stage 2 to stage 3 is going towards the gliosis, and we need to do when the gliosis is not increasing too much, otherwise the prognosis will be worse. And regarding the idiopathic epiretinal membrane, we need to keep in mind that at angio-CT we just see displacement, but the epiretinal membrane are not able to create any anastomotic capillary segment. So when we see changes in capillary free zone, is just a matter of displacement and traction. It's better to don't wait until stage 4 because then after the surgery, so the depth of traction will be much more, and after the surgery, this inner foveal layer persists and with the low recovery. We published also this paper looking to the sulfur increase in epiretinal membrane that correlated with the glial proliferation, and again was correlated with the intraretinal gliosis. We recently published another paper on the same topic. We want to have a look at the postoperative 3D movements of the retina due to the release of traction after the surgery. So we wanted basically to measure if the retina can go back after the peeling. And we found that, so we measured the shift of the retinal vascular crossing after the surgery from the retinal pigment epithelium. And we did this with the help of engineers that basically they just used the Pythagoras theorem to measure this relaxation index, that is our blue line. And we did the retest variability. So we had 95% of agreement between two different examiners. And what we found that a larger baseline relaxation index was correlated with the better postoperative visual acuity. So basically, we found that the post-op relaxation depends on the grade of intraretinal and epiretinal fibrosis before the surgery. So which is, of course, the results of a bridge between the Mueller cells and the ILM. So basically, we need to do the surgery when the gliosis is not too big. Otherwise, the retina cannot go back in position where it was before the surgery. What about the diabetic epiretinal membrane? We published this paper a few years ago where we found that if we are operating with the ILM peeling, the patient with the big intraretinal cysts, and we found that if it was greater than 400 microns, so we have this, we describe this floor effect. So after the surgery, you induce a further damage to the Mueller cells. So you have a resolution of edema, but the patient can see less than before the surgery because the damage of the peeling on the Mueller cells cut out of the connection between inner and outer layers, and the anatomy looks pretty good, but the function is bad. And we also found that looking at the correlation between the damage induced during the peeling through the GFAP and the Mueller cells, and we did the histology, of course, and what we found that there was an enlargement, it was saying before, of capillary free zone of deep vascular plexus. So the damage will be not only on the connection between inner and outer, but also on the perfusion of outer retinal layers, because the damage of macroglia will lead also an increase of capillary free zone of deep vascular plexus. So basically the FADs will be larger. And this decreasing perfusion of outer retinal layers, we will end up also in reduction of thickness of outer retinal layers. So let's, the biomarker for the diabetic one, the epiretinal membranes, is to do the surgery when the size of the cyst is not too big, and so less than 400 microns, and then when the the capillary free zone is not only already above the, let's say, 0.2. So at the end, we need to keep in mind that we need to understand the etiology of the disease. So we need to understand if it's an exudative pattern or a tractional pattern. And sometimes in diabetic patients, it's not easy because can be two entities together. So we need to understand which one is the one that is playing the major role at the moment. And then regarding the timing, we need to have a look at the intraretinal gliosis. We need to do the surgery, not when we see damage of outer retinal layers, but when we see the intraretinal changes in the first 90 microns. And then regarding the diabetic one, we need to do the surgery when the cysts are not too big and the deep the capillary free zone are not already too big. Thank you. And this is the last slide, just to remember what we were saying, looking at the morphology of the accumulation of fluid and intraretinal gliosis. So if we want to have a discussion here, and let's stop sharing.
Thank you very much. It was really interesting. Until my colleagues are thinking about questions and put them either in chat or verbally, I have two questions for you. The first question is, what do you think exactly happens with the Mueller cells? Do you think that there are any apoptotic mechanisms that are involved in the process?
Yeah. So I think that the macroglia try to protect the retina as much as can. So under traction, the Mueller cells started to increase this filament, intermediate filament, and we can see this increase of gliosis. And this is an idiopathic one. And the point is we need to recognize this biomarker in order to remove the traction that is inducing the gliosis. So it's something new because we are moving from, let's say, an epiretinal fibrosis to intraretinal gliosis that is another biomarker. And in order to recognize better, what is involved mainly in the reduction of visual acuity, because we know sometimes we have epiretinal membranes that they can stay there for months, sometimes years without any changes, and sometimes on the other side are running fast. And so that's why to understand when something is changing inside the retina. And so we found that it's better to have a look in the first 90 microns. In diabetic one, it's completely different because the Mueller cells is not strong enough to produce GFAP, but is induced to apoptosis more than react with the gliosis. And this apoptosis led to formation of intraretinal cysts. And then when are too big, then we do the peeling on big cysts, and so we can induce other damage on Mueller cells. So this is what we found that can be interesting.
Excellent. Thank you very much. Now we have a question from the audience. This is the first question from the audience. Do you have any tips and tricks to protect Mueller cells in diabetic patients? So if you have diabetic patients with membrane and you start the operation, what are your tricks and tips?
This is a very good question. So in one of my slides, I was showing that the Mueller cells are straight in the middle, okay, and they have this Zeta shape going towards the periphery, okay? So the point where are very weak are just in the middle, in the foveola. This is also the reason why the macular hole is right in the middle, because Where the Mueller cells are straight, they have no damping effect, so they cannot have, cannot reduce the traction. So because are straight, they cannot, preserve the area if the traction is right in the middle. So this we need to know, because when we do the peeling, I try to do, from the periphery to the center, so centripetally, because I don't want to stress furthermore the Mueller cells that are straight on the fovea. So this is like a sparing technique, okay? The point is not just because I'm afraid to induce a macro hole. That can be, but it's not the problem. The problem is are the metamorphopsia. So sometimes when we do this peeling very fast, crossing the fovea, okay, we can induce stress, more stress on the area where the Mueller cells are not so strong. So I'm trying to do centripetally, so doing going from the periphery to the center, okay, and then at the end I will have just a small tissue, okay, on the top of foveola, and then they will naturally go off, or I will just remove with the cutter gently, just with a bit of aspiration. And if we think about also the inverted flap, probably works also because we are not enlarging the edges. We are doing it centripetally because we want to invert the flap. This is a different matter, of course, a different topic, but the point is still to try to go towards the center to stress less the weak zone area.
Okay, thank you very much. There is another question, and it's related to the mixed type. When you have a mixed type, what is your evaluation algorithm and procedure, and then what is your therapeutic algorithm based on?
When, like in the diabetic one, I have a mixed form, I start with the injection. So I'll try to, remove the exudative part as much as I can, okay? Keeping in mind that if we do many injections like of anti-VEGF, the traction on the retina can increase, okay? So basically, I want to have a dry macula as much as I can because of exudative pattern, and then I will peel the tractional force if are present, of course. But I don't like to do the peeling if I'm not recognizing tractional forces, okay? So I'm not like to do the peeling in exudative form. I try to, treat the exudative form as exudative form. And if I see any also little traction, I will. So I do the peeling, but I know that sometimes in diabetic patient also inducing a PVD can be beneficial, but sometimes we are pushing too much to do the a vitrectomy just for a PVD induction. So this is the reason why I'm very concerned about the right diagnosis to understand if it's one problem or the other and to treat accordingly.
And when you are talking about pharmacological approach first, do you prefer anti-VEGF, or sometimes you are using steroids, or what is your general policy about this?
Generally, I'm going for anti-VEGF. Okay. anti-VEGF most of the time, and then to me still the steroids like the dexamethasone is not the first line in most of the cases.
Okay. Any more questions from the audience? Okay, I think that there are no more questions on this topic, so probably we can go to your second topic, Mario.
Yeah, of course. The second topic I will speak about the properties, performance of intraocular tamponades. Let me share the presentation. Just a second. Okay. So if you like, just stop me and we can discuss also in between as you like. So
okay, thank you.
First of all, I'd like to acknowledge my research group that is running between my university and also this laboratory analysis in Milan and in Genoa. So the choice of tamponade is done according to the configuration of retinal detachment, localization of retinal breaks, the status of the lens, so aphakic or pseudophakic, and the patient ability to posture, and also the patient need to travel by air. So basically is made on patient by patient basis. So in my presentation, I will try to answer the following questions. So how to choose between gas and silicone oil in retinal detachment, rhegmatogenous retinal detachment, myopic macular hole, PVR cases, and which kind of silicone oil in PVR cases, like 1000, 5000, and so according to the viscosity, and also according to the density, so heavy silicone oil or normal oil. And to make a choice, we need to keep in mind the difference in tamponade efficacy and the biocompatibility. Okay, these are two issues very important for the device that we are using. So this is related to tamponade efficacy to the surgery, of course, and to interrupt the communication between epiretinal and subretinal space. And the biocompatibility is another big issue because sometimes we can induce iatrogenic damage. And I will speak also, in deep according on the biocompatibility. So regarding the tamponade effect, we know that the tamponade has different aims. The first is instantaneous interruption of open communication between subretinal and preretinal space, flattening of breaks at the retinotomy edges, displacement of proliferative mixture, and also we want to displace also this proliferative soup from the posterior pole, because we don't want to have star folds, of course, on the macula. So, but the tamponade efficacy is related to the shape of the bubble. And the shape of the bubble is related to the density and the interfacial tension of the compounds. The density of the gas is 0.0012, so means that it's very light, so the gas goes up. Whereas the silicone oil density is just 0.98. So if we do 1 less 0.01, we will see that the number will be quite high. So the buoyancy of gas will be much stronger, much higher than silicone oil. 1 minus 0.098 would be just 0.02. And this is why it is important, because then the shape of the bubble, you see that is different. The shape of the bubble in the gas, we will end up in a larger contact between the compound and the retina. And this is important because if I have several retinal breaks, I can close all of them if are next to each other. In silicone oil, the arc of contact between the compound and the retina is lower. And so that means if I have multiple retinal breaks, probably I cannot cover all of them at the same time. And the second point is the interface. So this is the different morphology of the shape is related to the density. And regarding the interfacial tension that is higher in the gas, 70 Newton-meter, and lower in the silicone oil, 40 milli-Newton-meter, tells us about the forces that are on the surface of the retina and that tell us the quality of the tamponade effect, that will oppose a stronger surface in the gas bubble and the less less stronger, let's say, surface in the silicone oil. So the different density, different interfacial tension, we will bring to a different interface, different contact angle, different tamponade efficacy. To better understand, these numbers, we did an MRI to the few patients in order to have a domain of the vitreous cavity with the Berger space that that is the space behind the lens. And so this was the domain, the volume of the vitreous cavity. And the aim was to describe the configuration of the tamponade fluid in a realistic eye geometry. This is important because it can tell us which tamponade we need to use if you have different retinal breaks in different places. So we wanted to better understand the shape of the interface, the tamponated region, and the retinal coverage and the volume. And we had a look at the anterior posterior direction and inferior superior direction in emmetropic eye and also in myopic eye, according to the volume of the tamponade that we were injecting. So this was the real reconstructed eye shape. And this, of course, with the help of eye engineer, we did all these calculation. And what we can say that in the gas, the flatter interface, you can see here, there is flatter than in gas, than in silicone oil. Flatter interface means a better tamponade effect. So if we have gas in this vitreous cavity, the tamponade effect will be in arch larger, okay, than in one with the same volume of silicone oil. Okay, you can better see here. For the same volume, you can see here are two of the gas and here silicone oil. So for the same volume, you see that I can cover the area that is large, an area that is large in silicone in gas, where is smaller in the silicone oil. Okay, for the same volume. So and the meniscus, let's say the interface is flatter here than in silicone oil. So this is important because we need to keep in mind that the gas is always better. We need to use silicone oil for different reasons that we will speak about later. So, and we did the calculation, and at the end, we found that there is a difference in arc of contact, but both of them can reach the posterior retinal breaks in the same hour. So this is important because when we think about the covering multiple retinal breaks, we are always thinking about the peripheral retinal break. This is right because regarding the posterior pole, they are reaching in the same hour the gas or silicone oil. We need also to keep in mind that the tamponade effect in myopic eye is smaller than in a metropic eye. And also we need to remember so that the tamponade efficacy is reduced in highly myopic eye, and also the emulsion, if we use silicone oil, will be higher in myopic eye compared to the ametropic eye, because the shear retinal stress, and we will tell you, I will tell you later, will be stronger. So the contact between the retinal surface and the silicone oil will be larger, and with the saccadic eye movement, so with the mechanical forces, the shear stress induced by the oil on a bigger surface, we will end up in a higher emulsion. Okay, so how to choose between gas and silicone oil in myopic eye? The first choice is the gas, and we need to differentiate myopic macular hole without fovea schisis and myopic macular hole with fovea schisis. The first choice is gas because the oil cannot get in contact because of the lower density, cannot get in contact with the, let's say, the bottom, the end of the staphyloma, okay? Because stays in one bubble and cannot fit the staphyloma. But sometimes we have to use silicone oil in myopic macular hole. Why? In myopic macular hole and in myopic eye, we need to remember that we have a decreased pumping capacity of RPE because of chorioretinal atrophy. And then we have less compliance of the retina because of the ILM that is less elastic than the other tissues, and retinal blood cells. So in between, we have a fluid that is in the between the retina and the silicone oil bubble. So the silicone oil cannot reach the staphylomas, let's say the end of the staphyloma. This is the reason why now the silicone oil is not so common anymore in the myopic macular hole. That is not the topic of this presentation, but basically now to close a myopic macular hole, we are thinking about the inverted island flap, or to increase the retina extensibility, or to plug with autologous or heterologous tissue transplant like human amniotic membrane, or to increase the gliosis with platelets-rich plasma. But the heavy silicone oil does the same, cannot fit the end of the staphyloma, because the heavy silicone oil has an interfacial tension that is the same, 40 millinewton meters of silicone oil, and the heavy silicone oil is has a difference with the one of 0.03, so the same that as the light oil. It's just a matter of upside down position. And there's no difference between normal oil and heavy silicone oil in the outcomes in closing the myopic macular hole. But why it was so common, it's been used so much? Because when we use, when we have a staphyloma and we use silicone oil, we have just a compartmentalization of water. So these 5-10 microns of water, they can stay there, and there is not shear stress that is moving the water inside the staphyloma too much. So this like a pool, like a compartmentalization of the water. And when the patient is looking around with saccadic eye movements, the shear stress induced by the movements of the eye is not able to create a current to lift the edges of the macular hole. So at the end, we have not a tamponade effect, but a filling effect. So the eyes feel as full of water, and so the water that is in between the staphyloma and the silicone oil stays there, is not moving, and time by time, is the macular hole, will end up in a closure because the shear stress is less. Of course, the success rate is not so high, but as now we are getting with inverted Allen flap or other tissue that induce directly gliosis on the edges. So, and what about the choice of tamponade in PVR cases? So it's been published many years ago in the silicone oil study, then Schwartz published in Cochrane meta-analysis in 2014. Basically, when we have to choose between, in PVR cases, and for PVR cases, I mean from C, PVR C and more, so at least we need to have a star folds. And there's no difference between there is a difference between SF6 and silicone oil. So if I have to choose between SF6 and silicone oil works better. According to the Cochrane, there is no difference if we are using C3, F8 or silicone oil. No significant anatomical and functional difference, but the point is to use one or the other is if we are happy by the end of surgery, if we are happy that we have released the traction, there are no traction anymore, so we can leave a long-acting gas, C3F8, but if I still think that we can have some proliferation and I want to leave this compound for longer, even if I know that there's less tamponade effect, but I want to have a stabilization and I want to avoid that there's a diffusion of growth factor that can induce a further PVR, I will use silicone oil. Regarding the heavy silicone oil and light silicone oil, there is no difference according to the study that Antonia Houston published on ACTA in 2011. But the big bias of this study was that most of these patients had the retinectomy done. And of course, if we cut off the retina in the inferior part, then we can use also the silicone oil, because the light silicone oil, because I have no retina to tamponade anymore. So in this paper, basically, we know that the silicone oil can also work when we do inferior retinectomy, but still a space for heavy silicone oil room exists when you have localized area that you want to tamponade, and otherwise with the normal oil cannot reach. So what about the 1000 silicone oil and 5000 silicone oil? This opened another big discussion because because is the related to the biocompatibility and related to the emulsion. Okay, and we don't, I at least don't believe that 5,000 or 1,000 is only a problem of mechanical stress, because if we speak about only viscosity, we are speaking about the mechanical stress. And so I think that emulsion are much more related to surfactants that can induce emulsion more than mechanical stress itself. But this is an interesting topic that we need to speak a little bit more in details. So, and because now we are moving from the tamponade efficacy, we are moving to the biocompatibility. So this is the reason why we speak about the surfactants and mechanical energy. So the biocompatibility is related to the mechanical energy, chemical energy, and thermal energy. Let's start with the mechanical energy. So mechanical energy is the energy that is present inside eye. It is the energy that we increase in our system when the patient is looking around, and is the energy that we wanna reduce injecting oil with high viscosity, like 5,000 silicone oil. We need to, in eye filled with the silicone oil, we need to keep in mind that it's not possible to separate viscosity induced from gravity induced instability. So everything is together. So we need to analyze, we need to keep in mind the movements, the gravity, and the viscosity that is in our domain, in our system. And we did several measurements, and so we had this camera that was looking was moving and was looking the formation is emulsion according to the mechanical energy. At the end, we can tell that if we use the viscosity, the oil with the higher viscosity, like some oil where like in fluoron are adding 5-10% to high molecular weights component, the extensional viscosity will increase. So what is the point? The point is that the velocity between silicone oil and the eye, the shear rate, is lower, okay. But what we believe that is not enough. Even if we are using 5,000 silicone oil, we still can have emulsion. Because when there is the fluid that I was telling you before, that is in between the retina that is hydrophilic and the oil that is hydrophobic, makes the system equivalent in terms of mechanical energy comparing 1,000 to 5,000. So the emulsion is not just a matter of viscosity and mechanical energy. But the three steps of the emulsification, that are dispersion, emulsion, and creaming, are related more to the chemical energy. So are related to the surfactants that are compounds that can lower the interfacial tension. And if I have a lower interfacial tension, I need less mechanical energy to break silicone oil into small particles, so to have emulsion. So the surfactants are in the silicone oil, are in the packaging that we are using with silicone oil, are also produced by the surgeon and by the surgery, and by the disease itself, because are the proteins, and the proteins, if our surgery is not so clean or the disease is very aggressive, they are produced emulsifiers, so are produced surfactants that are able to decrease the interfacial tension. And then are impurity present also in perfluorocarbon liquid. Then when I have these small particles around, So they are able to decrease the interfacial tension, but also to increase the inflammation because they can induce phagocytosis by RP. They will work as antigen presenting cells and use a response to an immunogenic agent. So interaction between different compounds. This is a topic that is related on the chemical energy. So we routinely use liquid as a surgical device, okay? So we use dyes, we use perfluorocarbon liquid, triamcinolone, and but what we don't know much about the interaction that they can have, between. So we don't know if the dyes can interact with the perfluorocarbon liquid with the triamcinolone. So we have still lack of information about mechanical damage induced by the injection of the compounds, composition of single device, and chemical interaction, because at the end, we are looking at the functional outcomes, and functional outcomes are related to the disease, surgery, and also the interaction between all these compounds that we are using. So this is an 19 years old traumatic retinal detachment. Do you believe that these findings are related just to the use of silicone oil? We don't think so. I think that there are some surfactants that have induced the emulsion. And look, this is 59 years old male with inferior retinal detachment that was treated with heavy silicone oil. You see this inflammation, retinal inflammation was very strong, and just doing air fluid exchange, so the washout, just the water that was dropping on the retina was able to induce these two big retinal tears. And have a look, we were just removing the silicone oil. At the end, if you have a look in periphery, there were these white dots that are inflammatory cells all around. And there was a normal oil, there was removable silicone oil. So this is also something that we induced because we were using these compounds. And also, if you have a look, sometimes the optic disc is completely different from the disc that was before the injection of oil or other compounds. Look, we are collecting many cases on this topic because we are trying to correlate the lab findings to the clinical findings. This was a macula off retinal detachment, then was treated with the vitrectomy silicone oil, then silicone oil was removed, and but was used perfluorodecaline, triamcinolone. You know that you see there's something in between. The retina is flat, and also the autofluorescence. You have this hyper and hypo autofluorescence that looks something very strange, and for sure there's something related to the compounds that we have used. Or the sticky oil, everybody knows that interaction between perfluorocarbon liquid and silicone oil can induce the sticky oil formation. So let's go now step by step. If a company wants to introduce something on the market, his concern is to tell that that compound is not cytotoxic. So the single compound can be safe, but the interaction between them probably are not safe. And there are no studies that are looking on interaction, and also the ISO rule are not looking into the interaction. Let's start from the perfluorocarbon liquid. You know that when we were doing this experiment on a live pig eye, and we were measuring the real IOP with a measurement of IOP with the probe that was inside the eye, not outside, so inside. And what we found, when you inject blue, the pressure goes to 200 millimeters. And when you do scleral indentation, it goes to 200 millimeters of mercury again. And when you inject the perfluorocarbon liquid, it goes up to 300 millimeters. So we are inducing some mechanical stress, and we don't know about. Only injecting, the liquid, perfluorocarbon liquid or blue during the surgery. Of course, we are trying to reduce or close the infusion or use the dual bore or doing other maneuver to avoid, but still I think that is underestimated because nobody can feel that eye is reaching these high pressures. Regarding the perfluorocarbon liquid, we need to remember that just a few years ago, 3 years ago, there was have been found that perfluorocarbon liquid can be really toxic. And in a paper published by Pasteur, 117 eyes with pale optic nerve, retinal necrosis, hemorrhage, disruption of all retinal layers, the perfluorocarbon liquid was used during the surgery and was removed by the end of surgery, was not left inside. Something was wrong in that perfluorocarbon liquid. That perfluorocarbon liquid was from Alamedics, and according to the ISO, it was not cytotoxic. And then, in Spain, Pasteur was testing the same product, and they found that according to the ISO was cytotoxic. So were the same rules, why this difference? So we were trying to explain if the ISO criteria was adequate, why the toxicity was not detected, and if the H value that now is one of the chemical element that we are looking at, if was enough to describe the cytotoxicity. And we published a few papers on this argument. And the first one was to validate the cytotoxicity of perfluorocarbon liquid according to the ISO. And we did a risk assessment experimental design on variable cell sensibility, on the sample evaporation and the contact area, time. And what we found at the end, that the ISO criteria was adequate, but the Alamedics chose the wrong testing method. It chose the extract method and not the direct contact method, because according to the ISO, you can arbitrarily choose one type of the test, but the test condition must be validated according to the characteristic and the intended use. So perfluorocarbon liquid should be tested with another test, the contact test, not the extract test. But this was at the end was a compound that was on the market. And what about the H value? We cannot trust just the chemical analysis. We need also the cytotoxicity analysis, because we found that because some companies want just to show on the label the H value to say it's not cytotoxic. We think that is not enough. We need also a biological proof, because we found that even if we have low H value, the some compound can be cytotoxic, like the acid perfluoroctanoic, and sometimes with the high H value, the compound can be not cytotoxic. So, for the interest of our and the patient, so we need to have both biological and chemical tests. What about the silicone oil? The silicone oil, the biocompatibility depends also on the low molecular weight component. So the silicone oil is obtained by 3 steps synthesized. One is the polymerization. During the polymerization, and also produce impurity. Impurity is just a matter of dimension of the molecules, are not so reactive as perfluorocarbon liquid, but these impurity have a the low molecular weights component. And according to the ECA, that is European Chemical Agency, the low molecular weights component are the candidate list of substances of very high concern. What we did, we compared the molecular weight distribution of 10 different brands of silicone oil on the market. And we were looking at the low molecular weight component, and what we found, that there's a big difference between the different brands in the concentration of low molecular weight component. And so after this paper, there was a lot of pressure to ask the manufacturer to communicate the purity and quality of the characteristic of their product in understandable and clear manner on the label of the box of the product. But regarding the low molecular weight component, are not cytotoxic itself, and as you can see in this analysis that we done, but the low molecular weight component diffuse out from the oil to the ocular tissue, inducing chronic toxicity. So they can accumulate inside the tissue and can cause unpredictable long-term damage. So otherwise, we have the toxicity that we see after months, or the toxicity of the pale optic nerve, sometimes are related to diffusion of the compounds from the bubble to the retinal tissue, and we will have damage in long term. What about the interaction then between the proteins, so our surgery, and the silicone oil? So we added in the lab proteins coming from albumin, and so the one that is in the serum of the patient. And we found that adding albumin at a concentration of 70 gram liter corresponding to physiological serum content, the interfacial tension was reduced by half. So if our surgery is not clean enough, or there is still inflammation, the proteins produced can act as a surfactants. So the emulsification is related to the low molecular weight component, but it's related also to our surgery. And if we add the triamcinolone cannot change, it's not able to change the interfacial tension, but induce this pickering effect, so stabilize the emulsion. So in contact with the emulsion can only get worse because induce this solidification of the emulsion. And this is another good point that we are still working at. Are just preliminary results, and we found that according to the ISO rule in the lab, if we add the triamcinolone to the perfluorodecaline, we have a cytotoxic effect of reduction of viability of 80%, so very high toxic effect. Last point is for the heavy silicone oil, that we know that heavy silicone oil is an alkane semifluorinate, F6H8 plus silicone oil. Now, the alkane semifluorinate are very close to the threshold of cytotoxicity. The point is, everybody knows, and so they try to reduce the toxicity, reducing the biological interaction of F6H8, because we are using a longer chain of silicone oil that can trap the reactive substance, so can trap the F6H8. So this is the reason why now there is like Denstrom Extra, because they're using a more viscous oil in order to trap the F6H8. And we also described the interaction between heavy silicone oil and perfluorocarbon liquid that can lead to sticky oil formation, because when we use perfluorocarbon liquid, even if we do fluid air exchange and air fluid exchange, we still leave some perfluorocarbon liquid of the wall of the retina. We did the gas chromatography. You know, when you do air fluid exchange, then if you wait for a while, when after removing with the flute needle the perfluorocarbon liquid, the tiny amount of the perfluorocarbon liquid left on the optic disc, we analyzed with gas chromatography, had the same spike of decaline of the perfluorocarbon liquid that we were using. So basically, we leave perfluorocarbon liquid, and if we add heavy silicone oil, we have the formation in this hyperviscous solution, the sticky oil. And so the sticky oil is just because there is a contact between perfluorocarbon liquid and silicone oil. This happens more often if we use octane than decaline, more if we use heavy silicone oil than normal oil. This is because the octane has a high spreading coefficient compared to the decaline. So the point is to avoid, it's not just sticky oil, but it's also hyperviscous. The point is to avoid the direct contact between oil and perfluorocarbon liquid. Also, the temperature affected this interaction. So if we have the sticky oil formation, we go under air for a few minutes, the air will increase the temperature about to 28, 30, and then you will have, and then you can have a release slowly of the sticky oil. So the direct silicone oil perfluorocarbon liquids exchange has to be avoided. So we can conclude that injection of fluid significantly increase the intraocular pressure. So we need to look at using dual bore. Sometimes dual bore is not enough with the small gauge. So we need to do some different maneuver to avoid. Perfluorocarbon liquid itself is safe, but needs to be correctly tested because it can be very reactive. And regarding the interaction, proteins can lower the interfacial tension, so can interact with the silicone oil. Triamcinolone can interact with the perfluorocarbon liquid, so be careful because according to our preliminary result can be cytotoxic. And F6H8 and perfluorocarbon liquid are cytotoxic and can induce the sticky oil formation. Thank you.
Thank you very much. That was really, really interesting. I must say that really what you showed is valid not only for retinal surgery and silicone oils, but for lots of things that we are doing, because we have the safety for each separate of them. And after that, we use them together and we assume that the result is going to be safe, but actually it happens that sometimes is not. And also this very personalized problem that everybody has different biofilm, different environment, different tendency for information, and so on and so forth. Before my colleague asks questions, actually in the university hall there are quite a lot of colleagues and they just submit the questions in writing. I would like to share with you something and of course ask about your opinion. During the close-up for the COVID, I had a series of 5 patients which were diabetics, operated with silicone oil, and this silicone oil started to disperse into the anterior segment, like they had subconjunctival silicone oil. First question is, what do you do when you have subconjunctival silicone oil in one of your patients? Then I would like to share something which is even more interesting. All those 5 patients during the summer were sent back to their surgeons, which is far away from here, and they had their silicone oil removed. And at the beginning, everything was okay. But with time, I started to realize that behind the lens capsule, there are small bubbles of silicone oil that are growing and growing and growing. And one of them actually at the moment has quite a lot of silicone bubbles. It's very interesting. When I do indirect ophthalmoscopy and he lies flat, there are so many that actually they prevent me from doing indirect ophthalmoscopy. When I put him on the slit lamp in upright position and use different kind of lenses, I almost not seeing anything. And my question here is, do you think that there is a reverse movement of the silicone from the subconjunctival space back into the eye? Do you think that this is possible? Because I cannot imagine that it will grow from somewhere else, or maybe there is a depot somewhere. So what is your opinion about this?
Um, so thank you very much. Very interesting cases. And regarding the bubble of oil, in order most of the time I try to close the conch because try to move from inside to outside, close the conch and sclerotomies when I use silicone oil. If I find in the post-op, if I will find in the post-op the presence of oil under the conch, what I'm doing when I'm going to remove it, I'll try to wash out the subconch as much as I can. Sometimes you cannot remove all of them because are in between the conch and the tenons, and so stays there. Regarding that case, I don't believe that the intraocular pressure is so low that to allow the silicone oil to move from subconch to inside. Probably there is some emulsion that was trapped in between the anterior hyaloid and vitreous base, and then time by time are released and are able to move around. But I don't think that is that blab of silicone oil, subconch silicone oil that is still moving in, because should have a very low intraocular pressure to let the silicone oil get in. I don't know, what do you think?
Or very high extraocular pressure. I don't know, maybe they rub their eyes or something like this. I absolutely have no idea how it happened, but it was not only one patient, and all of them were diabetic patients. And all of them actually are having very good optical and functional results, which is interesting. All of them are phakic as well. So I don't know, maybe it was trapped somewhere and with time it was released. That was my initial hypothesis, but then
because if are phakic, probably the anterior hyaloid is still there and is trapping some bubbles and are releasing slowly by time.
Okay. Now we have a question from our audience, and this is biocompatibility. Do you equalize biocompatibility with safety? Because it looked like this, but if not, do you think that factors like surgical equipment, different type of surgical equipment, surgical technique may also play a role for safety? Do you think that biocompatibility is a little bit more narrow than the safety itself?
Of course, biocompatibility is so what we, for the medical device, we need to follow some rules that are the ISO rules. Okay, that the ISO rules are tested only in the lab, are not tested on the patient. It's not like a drug that we need to have like a big clinical trial. Okay, so they are tested in the lab. If they are not cytotoxic, they can be on the market. But of course, as you mentioned, it's completely different to have, a safety profile on several patients because are not running. If I want to, put on the market the silicone oil, I don't have to run a big clinical trial as for a drug. Okay, so and as you mentioned also, the point is that we don't know if we can mix all of them together, if they can become toxic, cytotoxic or not. So the safety is, I think, a big issue. Okay, and that I think there is a lot of information that we need to have still, to be, because for the perfluorocarbon liquid was unbelievable that the surgeon was using all around Europe, thinking that it was safe, it was a good product, and then the day after, retinal necrosis. So, and I still believe that the safety is something different, and we need to work a lot on this with companies to have a response that is clear for the product that we are using.
Okay, and one more question from the audience. There is a tendency for some vitreoretinal surgeon to put perfluorocarbon or perfluorooctane and leave it into the eye for some time. What is your opinion about this? Would you do it? And what do you think are the positives and negatives from it?
Okay, so why are using octane? Because the density is very high, so the meniscus is flat, so the tamponade effect is very good, but on the other side is very reactive. So, and I know that has been used for many years and still now for like 5-7 days and then removed. But there are also many other reports that perfluorocarbon liquid can be cytotoxic. And we don't know much again about the surfactants, the proteins and the endosurfactants produced by the surgeon and by the surgery, and if they can have any reactive reaction to the perfluorocarbon liquid. We don't know if in the perfluorocarbon liquid sometimes there are impurity like acid perfluorooctanoic, something that is very reactive. I don't like to use perfluorocarbon liquid most of the time, but I don't like even more to leave perfluorocarbon liquid inside the eye. If I have to leave something and I need to tamponade inferiorly, at least I wanna use heavy silicone oil because let's say the same family, the alkane semifluorinate are mixed together with some silicone oil. At least can trap a bit this reactive substance.
Okay, and I promise very last question from the audience. What are your criteria for taking out the silicone oil? Like if you can summarize when and what?
To remove the silicone oil or to use silicone oil?
To remove.
To remove, okay. So basically I'm using silicone oil when I am afraid that that case as can have a proliferation. Okay, so I want to leave that guy with silicone oil at least for 8 weeks, because we know that in 8-10 weeks are the, let's say, maximum expression of release of growth factor and proliferation. So after let's say 2-3 months, I can be happy or not happy about the presence of silicone oil. But the reason why I was using silicone oil was just for that 10 weeks from the surgery. So most of the time I'm going to remove after 3 months. Okay. Different is different things if after 3 months I still see problems. Okay, so that can be a inferior proliferation or a traction under silicone oil. So in that case, I will get in again. I will try to remove the problem, to fix the problem, and to put silicone oil again.
Okay, thank you very much. Thank you for your two fantastic presentations. It was really beneficial, and the science behind it, especially the mathematical knowledge, is really invaluable, because this symbiosis between practice and science is actually very important for future developments, especially in vitreoretinal surgery. So thank you very much again.
Hey, thank you very much. Buona Pasqua, good Easter.
Okay, for you as well. Our Easter is in a month, but have a good Easter. All the best from our team. Thank you. So now is exactly 2 o'clock Bulgarian time and 1 o'clock German time. So I have a great pleasure to introduce the professor in ophthalmology, Siegfried Briglinger, who is actually the director of the University Clinic at Munich, and who is a vitreoretinal specialist. I already mentioned that he did his specialty in his fellowship in Boston. And he dedicated part of his work on retinal transplantation, which is really a hot topic for today, because every one of our patients is asking exactly about this. By background, Siegfried is actually Austrian, and he finished his university in Austria, but now he currently works in Germany, and it's extreme pleasure for me to introduce him. About his special qualities, I would say that he's a runner as well, but he's not an Iron Man. He's just an Iron Father, because he's a father of 5 kids, which I think is really heroic, and for me is actually as much important as his achievements as a vitreoretinal surgeon. So Siegfried, the floor is yours.
Thank you, Christina. It's really great to be with you. Thank you very much for your kind invitation and for your very nice introduction. I also want to thank Mario, great talks, and I also learned a lot. The thing is that we actually should have maybe better coordinated our talks, but I'm actually happy that the repetitions are not going to be too often. Because my topic is vitreoretinal interface diseases, and as you know, epiretinal membranes are vitreoretinal interface disease as well. So what I'm going to talk about, I want to give an overview and short introduction to vitreous anatomy, pathology, pathophysiology, posterior detachment, pathophysiology of vitreoretinal interface diseases, clinical classification of the vitreoretinal interface diseases, and of course, last but not least, I think most important, the current treatment options. So to start with, a few simple things. You all know the vitreous gel is a transparent extracellular matrix. It fills the eye, volume of 4.4 milliliter. The outer cortex of the vitreous is mostly made of dense collagen type 2, and it's firmly attached to the inner limiting membrane, which is made of type 4 collagen. The detachment, posterior vitreous detachment, actually starts with a synthesis, which is a liquefaction of the vitreous. And the second step is the syneresis, a collapse of the central vitreous due to a rupture in the posterior hyaloid, posterior vitreous cortex, through which the liquefied vitreous flows into the retrovitreous space and separates the posterior hyaloid from the retina. Typically starts with a partial separation, the perifoveal region, and until it progresses to the optic disc. Then we have the separation at the peripapillary glial tissue from the optic nerve head, which usually, often the formation of a Weiss ring occurs, and then we have the accompanying symptoms when the patients show up. The Vitroidan Interface, the topic of the day, is an adhesive sheet of that facilitates the connection of the posterior vitreous cortex of the vitreous body of the LM to the retina. The Vitroidan interface consists of matrix proteins including laminin, fibronectin, and collagen type 4. These proteins act as an extracellular matrix glue. Disorders of the Vitroidan interface are characterized by an incomplete detachment. We have abnormally strong adherence of the posterior highlight face to the macula, and last but not least, an anterior posterior traction exerting by the synergetic vitreous pulling at the adherent sites on the macula, causing morphological and often functional effects. Imaging with optical current tomography has contributed significantly to the diagnosis and management of vitreoretinal interface diseases. There are actually 3 pathomechanisms which are involved in the development of these diseases. It's the vitreous traction, proliferation, and degeneration. If the vitreous traction predominates, the vitreomacular traction syndrome can occur. If the traction increases, we can get a macular hole. Although in the myopic maculopathy, vitreomacular traction plays an important role. In cases of an predominance of proliferation, we can have a macular pucker, or 2 special forms, the Vitroidan membrane with foveogenesis or the Vitroidan membrane with pseudohole. In cases when the degeneration is predominant, the so-called lamellar hole can occur. So today we're going to talk about all these diseases except macular pucker, which Mario has covered just perfectly in his first talk. And if it's okay, I'd like to stop after vitreomacular traction, macular hole, myopic maculopathy, and as a 4th topic, we're going to talk about the non-perforating lamellar holes, which cover these 3 topics here. So let's start with vitreomacular traction. The natural history of vitreomacular traction can be very different. Of course, it can stay stable. We can have a spontaneous release, which would be the best. We can have an increase in traction, and the worst case would be the development of a macular hole. So in 2014, John and colleagues investigated 230 patients for more than 1.5 years, for 18 months exactly. And what they found was that more than 50% of the patients stay stable, and in about 1/3 of the patients, they found a spontaneous release, and only 12% showed a deterioration, and only a few of them actually needed surgery. So this is an example. The patient first showed up in 2008, 80-year-old patient, which acuity was 20/30. You can see this vitreomacular traction, and he came back again 8 years later, and as you can see, it seems like there's no change at all. However, the visual acuity increased to 20/25, and the reason for that, as you all can imagine, was that the lady had cataract surgery undergone, and there was no need for intervention in concern to the traction, as it was stable. So to get an idea whether the course is depending on the appearance of the OCT, John and colleagues, they graded the vitreomacular traction with OCT, and they found that, as I said, that grade 1 is an incomplete separation of the vitreous. Grade 2 shows cysts, and the most advanced cases not only show cysts, but also, as you can see here, a red arrow, subretinal fluid. And as we just learned, the total cohort together shows a spontaneous release of about 1/3. However, if we just look at the grade 3 patients, these patients show a spontaneous release of up to 70%. So waiting seems to be quite a good option. As you can see here, in summary, we have a spontaneous release in patients with vitreomacular retractions about a third, and if there is subretinal fluid existing, we can even tell the patients that they have a chance of spontaneous release in 70%. We don't do any treatment, therefore we have no recovery phase, and deterioration or complications will only occur at about 12%. In this series, the colleagues only performed surgery in 4% of the patients where they developed the macular hole. Now, what are actually the other treatment options? We have vitrectomy, pneumatic vitreolysis, and enzymatic vitreolysis. Let's start with vitrectomy. Of course, if we do vitrectomy, we remove the vitreous, we will have a 100% success rate in concerns of the release. However, the recovery rate is pretty long, 2 to 6 weeks, and it was shown that about 10% of the patients develop a macular hole, and a few patients also showed retinal tears. The costs are definitely higher, and it's definitely a much higher complexity than it's a very complex surgery, which is definitely especially compared if you do pneumatic vitreolysis. So what about vitreolysis? Just for the younger fellows, vitreolysis means that pneumatic vitreolysis means that we inject gas, about 0.3 to 0.5 for 100% SF6, C2F6 or C3F8 gas. And we then inject, with this procedure, we have a release rate of 80%, which is very high, with a shorter recovery rate compared to the vitrectomy. And interestingly, there's only very low complication rate. So in this series, 2 series published, they only found 2% of retinal tears and only 2% of patients developing a macular hole. The costs are definitely lower than compared to vitrectomy, and the complexity of surgery, as you can imagine, is lower. And if you now look at patients who already also had not only vitreomacular retraction, but also grade 2 macular hole, in these cases, there was a release rate of 100%, and 60% of the patients, 66% of the patients even showed a closure of the macular hole. I can show you an example. Sorry, here it is. You can see the patient starting with 20/60, vitreomacular retraction, small hole, and after the injection, the hole closed and took a few months until the subretinal fluid was gone, which acuity increased to 20/40. Now I have to go back to show this slide because there is one reduced prognosis. You have to look for Retinal membranes and also look for other diseases of the macula, diabetic retinopathy or AMD, because in these cases you have a reduced prognosis 50% and 25%. So last but not least, or least, because enzymatic vitreolysis has a very bad prognosis, we have learned that in cases, even cases smaller than 1,500 micrometer attachment, we have only 40% release rate. The recovery phase is pretty long, up to 6 months. We have a high number of complications, especially a subretinal fluid, which was found that this takes often a month to go away again. And the costs, as you all know, they are very extensive, even I think about 2,000 euros in Germany. So we actually don't really, at the moment, not really very keen on doing this procedure. And if you decide to do it, please only do it in cases where you have where you find the so-called positive prognostic factors, which increase the success rate up to 70% or 80%. It was found that if the patient is younger, it's female, it's phakic, a macular hole smaller 250 micrometer, and the vitreomacular retraction base is more than 1,500 and no retinal membrane, then you can increase the success rate even with enzymatic vitreolysis. So in summary, what are the recommendations for the management of vitreomacular retractions? We can observe and wait if the patient has a good vision acuity, no metamorphopsia, the duration is short, and if we have a full thickness macular hole, a small one, you still can wait a few weeks. It's recommended to perform treatment in cases of distinguished acuity loss and metamorphosis, if the patient has impairment of daily life, and of course, if there's a progression of direction-related changes. So what is the best to do? Vitrectomy is recommended in cases of broad adhesion, if there's attractive retinal membrane, and if there are additional retinal pathologies like AMD or diabetic macular edema. Pneumatic vitreolysis is quite a good option in cases of focal adhesion. In cases, for example, if you have patients who can go into OR, so if we have a need for a non-surgical option, and we definitely should look for epiretinal membranes in diabetic retinopathy, which will decrease the success rate. If you do enzymatic vitreolysis, and of course we have to offer this to our patients, have to know the options. Please just do it in cases of, if you find the positive prognostic factors, and also don't do it in cases of epiretinal membranes and other retinal pathologies. So this was the first part of my talk. I'm happy to discuss vitreomacular attraction if you'd like to, but I can also continue. Christina, just let me know.
Can you just tell us a little bit more about the pneumatic vitreolysis, how exactly you do it?
Okay, no, it's my pleasure. So it's actually the most important thing is that you should know that you should know how to handle the gases. The different ones. I prefer C2F6 gas, and I need let me just think about. I think it's a 41 gauge needle. It's the gray one. Sorry, this is something my nurses know even better. I know I use a 2 milliliter syringe, and then inject 0.3. And to be honest, I increase as much as possible. And then if the intraocular pressure is too high, I perform a paracentesis and remove some fluid, aqueous fluid from the anterior chamber. Of course, doing this with a fundoscopy, and as long as the retinal perfusion is fine, then nothing should happen. And then you tell the patient to go upside down for 1 or 2 hours. And to be honest, we have found that it's even better that the patient kind of moves, goes down again and up. So you have the movement of the bubble kind of increases the chance of a detachment of the vitreous.
That was exactly my second question, which is related to the positioning of the patient, but you answered it very well. And do you have any special criteria for observation, like something which in your practice, it's not like written rule or something like this, but you're applying, because those patients are not so rare anymore. And we see more and more of them because the age of our patients increases anyway. So we see quite a lot of patients with vitreomacular traction. Do you have any rule of thumbs that you're applying to observe them? And do you have any special tips on OCT for observation?
Okay, it's 2 important things. First one is the patient is the one who decides what to do, because actually you can't really do most of the times you can't do something wrong. Usually patients, I'm not the first one to discuss his problem with the patient, so most of the patients come and have problems for many months. So in many cases, we then finally decide just to wait a few weeks, to wait 1 or 2, 3 months, and then make an appointment. And if it has changed, then we would wouldn't have to do anything. Otherwise, we'd go to surgery. So concerning your question of science and OCT, I think the study published by John and colleagues gave us the answer. Actually, if you have a grade 1 for a long time, and the patient has metamorphosis, I think it doesn't make sense to wait for a longer time. If you have an attached vitreous, just a very small region, and we have grade 3 already subretinal fluid, you can tell the patient that he has a high chance of improvement without doing anything. So this is actually kind of a mixture of the urgency of the patient, how long he wants to wait. The patient knows that the success rate is very high. The risk of complications very low. So many patients decide for surgery. And the funny thing is, I actually thought that pneumatic vitriolysis would be the first option most of the patients go with, but the idea of injecting something into the eye, many patients don't like. They prefer doing vitrectomy when after having explained how it works, because just to make sure that the 100% chance of getting rid of the problem is finally for many patients a better option.
And the last question is, if you actually did the pneumatic vitriolysis and by some reason you were not successful, because the success rate obviously is not 100%, do you have any drawbacks for the vitrectomy that is following? So if you, after pneumatic vitriolysis, you decide to do vitrectomy, do you have anything special that you need to consider?
If pneumatic vitriolysis does not work, there must be a really very strong adhesion. Actually, this is the same also with enzymatic vitriolysis. If the adhesion is really strong, and make sure that you work with triamcinolone, that you mark the vitreous highlight so you can better visualize where to work with your vitrectome, with your cutter, and increase the vacuum. But you don't have to be afraid that the surgery itself is going to be if there are not more risks than without having done pneumatic vitriolysis. What you also can do, by the way, you can also do pneumatic vitriolysis after unsuccessful enzymatic vitriolysis. So you can change as much as you like. There's no danger no additional danger for the retina than just deciding to go for one option.
Okay, thank you very much. I think that there are no more questions, so we can continue with your presentation.
Okay, so now what if we have an increase in interaction and the hole is big already, a macular hole occurs? This is going to be the second topic. And if think about the pathophysiology, we actually can go back to, maybe it's an Italian, by the way, Mario, an Italian ophthalmologist, Grignolo. He, more than 50 years ago, 70 years ago, first described the relation between the vitreous and the development of a macular hole. So he was investigating the eyes, and he found that from the external surface appeared that there was a continuous membrane from the ora serrata to the posterior pole. And except the vitreous base and the macular and the disc, there was but there was a firm adhesion. And in these two regions, just by manually separating the vitreous, he could not separate it from the retina without breaking its surface layer. So it's about 70 years ago that the ophthalmologists realized that the vitreous detachment kind of plays an important role. I mean, today it's very easy, as you can see here with this beautiful OCT images. Here we can see the vitreous traction at the fovea, and it's kind of absolutely clear that vitreous detachment plays an important role. We mean by no, and this is kind of we all agree on, that we have two steps. We have the first step, which is an anterior-posterior traction of the vitreous, and then the second one, tangential tractions by proliferation and traction of glial cells and contraction of these cells, then secondly lead to an enlargement of the macular hole. and which is also kind of accepted in the community. We know that in order to remove these contractile elements, we have to remove apparatus and ILM peeling. This is necessary for two things: in order to increase the closure rate on the one hand, and secondly, to reduce the risk of a reopening of the macular hole. So this is actually quite clear. We don't have to discuss this anymore. The question is, how can we improve the success rate of the macular hole surgery? And is there kind of a perfect technique? I think most of us agree on that we have 5 steps for a successful macular hole surgery. We have to completely remove the vitreous. We have to remove apparatus and membrane, and in bigger holes also the inner limiting membrane. Especially in bigger holes, it's essential to intraoperatively close the hole, so to give the hole the chance to get closed afterwards. We need a tamponade, depending on the hole size, from air to gas or silicone oil. And last but not least, positioning is necessary, also again depending on the hole size. So these are the 5 steps. And we all know with a normal kind of macular hole, the chance of a closure is extremely high. We also see papers where they published up to 100%, which is not really which is kind of always difficult to publish. Anyway, 90% is definitely not uncommon. So, but what about the holes, the bigger ones, the persisting ones? I think in these cases, an intraoperative hole closure is very important. Actually, we are doing many techniques, and it's kind of really difficult to decide for oneself what's the best. But maybe I can help you with this summary. We have actually 3 techniques to close the macular hole. We have the aspiration and drainage techniques. We can use techniques where we use contraction to close the hole. Last but not least, especially in very big holes, we can use tissue for a replacement. Aspiration can be done only with alone with a fluid needle. A fluid needle, I prefer a needle with a soft tip, but we can also do it with a 41 gauge needle. And in bigger holes, we can also combine this technique with an induction of an iatrogenic detachment, and then after fluid air exchange, aspirate the fluid in the hole. Contraction techniques are actually 2 on the market, kind of. It's autologous bladelets, which have been used for many times, and all the ILM techniques, the flap and the graft, are actually contraction techniques which lead to a hole closure after surgery. And in cases of a big hole, we can use either autologous retinal transplants, we can use amnion, and you can also use lens capsule. So let's go through the different techniques here. First of all, the very simple one, this is my major favorite actually. After fluid exchange, I'm using a fluid needle with a soft tip and gently remove the fluid in the macular hole, thereby closing the macular hole. This also has been described just recently, a technique with a 41 gauge needle. This is kind of a little more dangerous, I believe, because you have to go very close to the RPE, and there's always the risk of a damage of retinal pigment epithelial cells. This is how it can look like. Beautiful images, pre and post-operatively. This is how we would like to have our macular holes. But what about cases of bigger holes and long-lasting holes? In this case, we can mobilize the retina close to the fovea. Also in this cases, we use a 41 gauge needle to inject BSS. Only at the end, try to get a connection to the macular hole, and after fluid exchange, you can close the mobilized retina by using a fluid needle. Also an example, very big hole, basic diameter, I suppose this is about 800, 900, and this is how it can look like with this technique. Now we go to the autologous bladelets. This is something which has been described for a very long time. the difficulties to get the platelets kind of has stopped for many doctors to use it because it's not that easy, or the processing. However, it was shown that you can also improve the closure rate by, at the end of the surgery after fluid exchange, put 2 or 3 drops of autologous platelets on the hole, and this increases the chance of a hole closure. ILM flapping graft, I think we don't have to discuss it because it has been discussed and talked and published so many things about it. You save some ILM at the margin of the macular hole, then either put it in or on the top of the hole, and at the end, this increases the chance of hole closure up to 100%. However, we have to be aware that we sometimes see an incomplete healing. As you can see here, the hole is closed. However, you have some remnants of the ILM, so that's actually the reason why I don't really like at least the ILM graft, which means that you put in the ILM into the hole. This closes the hole, however, it takes a long time for a vestitio ad integrum. The question is just a recent publication. What is now better? Should we drain, or should we use ILM peeling, ILM graft patches? This is an interesting publication from 2018. What they found is that also in very big holes, you can see here 660, the closure rate is very high, 100%. However, it looks like that the visual acuity in at least this series was better in the subretinal cases because there was no case of patient where there was a decrease in visual acuity in the subretinal aspiration group compared to the ILM group, where we had 10% of the patients who show the decrease, maybe because there was still some remaining tissue of the ILM inside the hole. So now let's go to the bigger ones. Just two videos. You can see we have 2 opportunities. We can either use some retinal transplants from the same eye, from the periphery, and then under heavy liquid, put it on top of the macular hole, and this kind of you can close the hole. Of course, visual acuity in the center will not improve, but still the detached retina close to the macular hole will attach, and then we still see some minor improvement also in concern of visual acuity. The second opportunity is case of our clinic. You can see a complete posterior, complete detachment of the retina with a big hole. I first try to mobilize the retina, and as you can see here, it's very stiff already. So it's kind of clear that it might be difficult to close the hole. So what even under air, the hole closure is not possible. Of course, you have to check whether there's some remaining ILM, which I just do right now. So it looks like that the surgeon before has worked perfectly and has removed all the ILM. So the only chance I saw in this case was to use a ILM, to use a amnion membrane, which is inserted through the trocar. It's sometimes quite difficult to spread the amnion membrane, so it kind of makes sense to use a chandelier light and then work with 2 swabs. And here you can see that at the end, it successfully put in the amnion in the hole, and this made it possible to close the hole and finally reattach the retina in this case. So the big question is now, what is the best technique? The winner is, I listed the most recent publications here with on different techniques, as you can see here, and found that there's a very high success rate, even up to 100%, and the worst one was 78%. However, it looks like that if you compare these techniques, that the aspiration techniques seem to be seem to be the only one to show a significant improvement. If you compare to all the other techniques, we only saw some slight improvement in visual acuity. So my personal favorite still is aspiration. They only use the other techniques in special cases. So in summary, the recommended therapy for macular hole surgery, we can observe and wait also in macular holes if it's a small macular hole with a vitreomacular adhesion, of course. It should be a short history, and I usually observe up to 3 months to look how it develops. Treatment is necessary in cases of grade 3 and 4, and in cases of persistent macular holes, grade 2. You can do a pneumatic vitreolysis, as we just heard before, in case of grade 2 and focal vitreomacular traction. Be aware that you definitely shouldn't do it in cases of aberrated membranes and diabetic retinopathy. Vitrectomy and ILM peeling is recommended in the other cases. You always have to remove tractive aberrated membranes. So if it's a small macular hole, small means nowadays smaller than 600. This is what we learned from the Manchester study group. In smaller cases, I personally use aspiration with a fluid needle. If bigger ones, it makes sense, and I succeed in closing the hole by inducing an additional iatrogenic retinal detachment. You can also use additional platelets in cases of huge macular holes, and if it's just really very, very large ones, then you either can use amnion transplants or autologous autologous retina to close the huge holes. So, Christina, this is the recommended treatment for macular holes, and I have finished the second step of my second part of my talk. Any
Thank you
questions? I'm happy to answer your questions.
Thank you very much, Siegfried. The first question, of course, is regarding the amniotic membrane. We saw the movie that you showed that it looks like the amniotic membrane, which is prepared for the anterior segment. Do you have any special recommendation for this membrane, or you just use the ordinary one that comes from the tissue bank and just punch it with what size is the punch, by the way?
This is actually the really big problem is the punch. We have one from I think it's about 50 year, kind of very old. You can't get these punches anymore. This one is 2 millimeters. This is the smallest I could find in our OR, and you just take the amnion membranes from the bank. It's no special treatment. If you don't need any special treatment before.
So it's basically the amniotic membrane that is used for anterior segment.
Yeah, it's exactly the same. So I asked for an amniotic membrane, and they just bring the same one we get for corneal and surface tissue diseases.
Because I'm asking because basically amniotic membrane, which is used for the anterior segment, varies in thickness. And this depends on the donor and depends on the manipulation of the membrane as well. So I would guess, guess that you need the thinnest possible one. So maybe it should be a special one. That's why I'm asking actually.
Okay, I got you. I think what I usually try to do is to get rid of the stroma. So if it's a thicker one, you can even separate some layers. I try to get rid of it and then do the transplantation.
Okay. Do you have any experience with the lens capsule?
Yes, I have, because it's a long time ago when I had no amnion and with me, and actually this was a case of a patient who had already undergone several surgeries where the retinal periphery was definitely no source for transplantation. So at good luck, there was still some lens capsule available, and I used it, and I could close it. Yeah, because also lens capsule induces fibrosis. This actually leads to the closure of the macular hole. In these cases, I most of the time inject silicone oil, and at least wait 6 months. little bit longer than I usually wait for removal. And so from the N1 experience, I can tell that it works.
Okay, there is a question from the audience asking, do you have any special technique for positioning the graft? So do you have any special tips how to actually position the graft and prevent it from extrusion movement or whatsoever?
Yeah, what I usually try to do, in this case, it was easy because the retina was detached. So the question, so what I do if it's not detached, I gently lift the macular hole, make it even a little bit larger. So that's the only way that you can put the membrane under the retina, and then you don't have to be afraid of to lose the membrane. So just to put it on the retina will not work. You have to kind of fix it.
Okay, and
the only possibility would be to put it on it and to do fluid exchange and put in silicone oil. But sometimes I'm actually, so if there's no retinal detachment, I just like to do gas or air, and then it must be underneath the retina.
okay, but you also did put them over the retina and put silicone oil, and that works as well.
To be honest, I haven't done it yet, but I believe it will. And I know colleagues doing it this way. This should work as well.
Okay. And then there is a research question. Do you have any experience or knowledge about combination of platelet and graft on the same go, and any any benefits out of this?
I have some experience, but not with not in combination with grafts. I have experience in combination with the aspiration techniques. So, for example, what I like to do in myopic macular holes, or even persisting large macular holes, to induce an iatrogenic retinal detachment, then close the hole, and at the end of the surgery, after fluid exchange, put in some autologous bladelets. This works really good, but I have no experience in combination of kind of whatever ILM or amniotic membrane, and then finally also do autologous bladelets.
Okay, yeah, but
the reason for that is because these are combining aspiration technique and autologous bladelets means that you combine two different techniques, which makes sense. But combining two contraction techniques, ILM and autologous bladelets, it's the same pathologic, the same mechanism. I think it makes sense to combine different mechanisms.
okay. I do not see any more questions. Colleagues, if you have any questions, please either chat them or send them.
Okay, so you want me to continue?
Yes, please.
Okay, so it's the third pathology, which has as a major pathomechanism the vitreomacular attraction. It's a myopic maculopathy. Just a short repetition. We have about a third of the patients will develop this maculopathy in high myopia. Posterior staphyloma leads to an axial elongation and increased vitreoretinal attraction. So interestingly, there's a stiffness of the retinal vessels and a stiffness of the ILM, and this leads to a thickening of the retina, so vitreoschesis and edema, and also to the macular retinoschesis I just told you. So it's interesting to observe that the myopic tractional maculopathy has a very high variability of clinical courses. So if it starts with a schesis, and they can a pseudohole develop, as you can see here. But on the other hand, some patients first develop a local detachment, subretinal fluid under the fovea. Patients having developed a pseudohole finally also can have some subretinal fluid, and mostly, in the worst case, end up in a macular hole with a huge retinal detachment. In cases of initially local detachment, you also can have sheaths then with detachment, but sometimes patients directly develop a macular hole, as you can see in this patient. But in the end, all those cases, all those patients, in the worst case, end up with a macular hole and with a huge detachment of the retina. So from the symptoms, it's good news, but also bad news, because sometimes patients have, many patients are asymptomatic or have only few symptoms, and then you don't know, should I do surgery or should not do eye surgery. Mostly show a slow progression of visual acuity deterioration with a very highly variable degree of visual acuity loss. And this makes it really difficult with a very poor correlation between OCT and visual acuity. As you can see here, the patient on the left-hand side has a visual acuity of 20/20, on the other hand 20/30. And you also saw patients showing even less changes, having a decreased visual acuity lower than 20/40. Metamorphosis and scotomas are in general rare, except in cases when the patients have developed a macular hole. The natural course, depending on the publication, we see progression between 15 and 69%, a follow-up period of 5 years. Prognostically unfavorable patients with a significant fovea sheaths and attraction of the vitreous or retinal membrane. Favorable patients with a vitreous detachment, we even, I know it's rarely, but we still see patients showing an improvement after a vitreous detachment. So the actual treatment we perform is a vitrectomy, and we have learned that ILM peeling is essential and necessary because we see a higher success rate compared if we don't do the ILM peeling. We have a quicker resorption of the subretinal fluid and a faster regression of the myopic fovea sheaths. However, we also see a progression to full-thickness macular holes when we do ILM peeling. There's a risk up to 21% in one 2007 published. So it's quite a risky surgery. We have the risk to do harm with ILM peeling. Therefore, it has recommended, here you can see some images of Hiroko Hirasaki. She is suggesting to do a foveal-sparing ILM peeling, which means that you avoid, in order to avoid postoperative macular holes. You can see here, after removing of the vitreous, you finally do the ILM peeling, but you spare the region around the fovea. I brought 2 cases to kind of show you how this works. It's a fovea sheaths with a small local retinal detachment, which acuity is 2100. And you can see some images of the video. The vitreous has already been removed. I have stained the ILM with a mixture of trypan blue and brilliant blue. And what I usually try to do is to peel towards the center of the fovea and not centripetal. And of course, this has to be done very slowly. Do it in a very gentle manner. The retina is kind of detached, and as you can see here, this is the area of the macular hole, and you leave this ILM area here just to make sure that by removing the ILM in the very thin area of the fovea, not to avoid the risk of inducing a macular hole. This is the OCT image a few weeks later. Visual acuity, lucky us, improved to 20/40, and we did not induce a macular hole. The second patient also has fovea sheaths with retinal detachment, but not a small, but a huge retinal detachment. So, and as you can see in the video right now, the retina is very mobile, and compared to the first case, we not only have an ILM here, but we also have epiretinal membrane. The blue stuff here is epiretinal membrane. The yellowish stuff is kind of a posterior highlight. And only after having removed all these different epiretinal tissues, after a second stain, you can stain the ILM, as you can see here, and then again just gently remove the ILM and leave the area of the fovea. Of course, it's not a must. Yeah, in cases where you can see in the all OCT cuts, you can see that the retina still is thick in the fovea region. You can completely remove the fovea. However, to be honest, I've seen so many patients referred to us with a macular hole after peeling. In these cases, I really would recommend to spare the fovea and make patients and us happy. Visual acuity in this case improved from 2060 to 2030. Also, another case with fovea sparing ILM peeling. So this was a few words to myopic maculopathy before we go to the last part, which is going to be a little bit longer. Let me ask you whether you have some questions concerning the myopic maculopathy. Christina?
Yes, yeah. I'm on. There is only one question. Do you see any correlation between the degree of myopia, like the dioptric power of myopia, and the optical result of your surgery? I mean, is it different if the patient is -8 and -14, for example? So
it is different. It is the surgery itself is a little bit more difficult because the longer the eye, the more difficult it is to get to the posterior pole. So you need special longer instruments to handle these patients. And if the question was in the direction of how is the about the visual acuity outcomes, also the visual acuity outcomes are usually worse in cases of high myopia because we have other changes. Additionally to the retina, we have changes of the RP and the choroid, as you know. So you will have worse less improvement in high myopic patients.
And what is the most common complication in high myopic eye when you do IML peeling?
The most common complication is development of a macular hole, and that's the reason why many of us just use the technique of lamp sparing peeling, and only in cases where we preoperatively see that the OCT shows a very thick retinal fovea, then we remove the complete ILM. But the results in concern of recovery of the OCT is the same whether you remove the ILM with the fovea or not. So you don't have to be afraid that the results will be worse by keeping the ILM in place of the fovea.
Okay, thank you very much. I think that we have no more questions on this subject, so you can go ahead.
Okay, so then in addition to Mario's talk, I'm now going to talk about the so-called non-penetrating macular defects. We call these three entities the epiretinal membrane with foveogenesis, the epiretinal membrane pseudohole, and the laminar hole are also called non-penetrating macular defects because they all have one clinical finding together. It looks like if you look into in the eye, do a fundoscopy, it looks like it appears like a full thickness macular hole. However, the Watzke-Allen test is negative, so we don't have a defect. However, we have metamorphopsia. Most of the patients have metamorphopsia, and they also have in common that the visual acuity, at least at the beginning of the disease, is quite good. We often see patients having visual acuity up to 20/25. Nowadays, based on OCT, we distinguish between three different types of non-penetrating macular defects. Just published from Hübschmann and colleagues, we divide between pseudoholes, epiretinal membrane foveogenesis, and lamellar holes. Pseudoholes have an epiretinal foveal membrane with an aperture here in the middle. We have a steepened foveal profile and an increased retinal thickness, as you can see here. The epiretinal membrane foveogenesis has, of course, the epiretinal membrane and typically this retinogenesis in the Henle layer. And in contrast to lamellar hole, pseudohole and epiretinal membranes don't have any tissue loss. But we see tissue loss in lamellar holes. As you can see here, typically we have this foveal bump. The lamellar hole show an irregular contour of the fovea, and a foveal cavity with undermined edges. In advanced cases, the lamellar holes develop disruption of the ellipsoid zone, but we have a normal paracentral thickness in contrast to the pseudohole, and we have the typical so-called lamellar hole associated proliferation, which is also called LHAP. I think histopathology shows it perfectly what's the difference between these two tissues, the entities. Here you can see the so-called LHAP, lamellar hole associated proliferation. Is an amorph structure which on OCT appears darker at the edges of the holes. You can also find this LHAP in the other entities. However, as more than 80% of lamellar holes have this tissue, it's called lamellar hole associated proliferation. And in contrast to apparated membranes, which appear white on the OCT, you can see in the immune histology these elastic structures, and you can even imagine how they induce traction in these interface areas. As most of the time, we don't see the typical cases like I just showed you. We have many mixed forms, and it's kind of important to observe whether there's more epiretinal tissue which looks more like epiretinal membranes or this amorphic structures like the LHAP. And then it will behave more like a lamellar hole in contrast to the other entities. So the big question is, when and how should we treat non-penetrating macular defects? Well, to answer this question, we should kind of first look into the literature. This is a study of our clinic, how the holes develop without doing anything, without performing treatment, and how these patients develop with doing the treatment which was recommended in the last year's vitrectomy. So what about natural history? If we look at pseudoholes, we learned that these patients show over the years a deterioration. In our observation, we found there was a deterioration from 2025 to 2030. In contrast, lamellar holes stayed stable for a long time, with one exception. Those lamellar holes who also had an additional apparated membrane, as you can see here in this case, they also showed a slow deterioration. So what about the treatment, vitrectomy? In our cohort, we found that if we perform vitrectomy in patients with a pseudohole, the patients on average show an improvement. It was an improvement from 2050 to 2025. In contrast, lamellar hole patients didn't really show an improvement. It was a minor improvement, and patients did not really see many difference. So, except those patients who also, like in this case, had a apparated membrane. You can see here after surgery and before surgery. These patients also improved from vitrectomy. So the treatment recommendation for the last years, at least in our clinic, was if we have a patient with a tractive apparated membrane, as you can see here, this would be this region. Also, the apparated membranes with foveal because they also have tractive components. Do the vitrectomy, remove the apparated membrane, but also the LM. In the patients with a long-lasting lamellar hole, reduced with probably not too much symptoms, it's better to wait and see because they often stay stable and do not really improve of a just simple vitrectomy with peeling. So let me just show you 2 or 3 cases. This is a mixed form patient, 64 years old, with Acuity 2016, epiretinal structures, tractive membranes, metamorphosis are strong. The indication clear to perform a vitrectomy and do the LM peeling. Post-operative, you saw 3 months later, improvement of visual acuity, and the metamorphosis are back on. Another case, also mixed form, here the membrane, but here the changes of which look a lot more like a lamellar hole. Visual acuity was 20/50. Again, metamorphosis quite strong. We performed the vitrectomy, the patient improved. Visual acuity didn't improve that much. However, the patient was happy because the metamorphosis had been reduced. But what about this patient? It's a macular hole now. You can see, typical case, no aberrated membrane. Here the LHAP formation, loss of tissue, irregular contour, which Acuity is 2030. Metamorphosis, yes, existing, but not too much. No aberrant, as you can see here in this all fast images, no aberrant and attractive structures. So we therefore decided not to do anything, just to wait and observe and look how it would develop. However, in this case, over the next year, the patient started to develop, on the one hand, decrease in visual acuity, an increase in metamorphosis, and as you can see here, we also had some defects of ellipsoid zones. So, but there was still no traction. So what to do with this case? The only thing we could do would be to do a vitrectomy and ILM peeling because there was no aberrated membranes. However, we decided, as we found one publication of Gonzalez who showed a patient with a successful treatment of an aberrated treatment of a lamellar hole with autologous bladelets. So what we did, we performed the peeling and with the ILM peeling, and at the end also injected some autologous thrombocytes. Sorry. The reason for that is because we found a machine which actually was used by orthopedics to produce high concentrated platelets. It's a special type of centrifugation which automatically separates platelet-rich plasma, serum, as platelet poor plasma, serum eye drops, and the red blood cells. And this gave us the opportunity to produce 8 times higher concentrated platelets compared to the others. There was a very low number of leukocytes. This is how it looks like after vitrectomy and peeling of the ILM. You inject 3 drops of the platelets. The patient then at the end has to lie lie on his back at least for 1 hour, better for 2 hours. And now you might ask, what's the mechanism? How would this autologous platelets work? Well, the thrombocytes are very rich of growth factors, and if they get in contact with disintegrated neuroretinal tissue, the thrombocytes are activated and release these growth factors. And the idea is that they support the wound healing by regulation of the Muller cell proliferation, migration, and contraction. And this is how it looked like. This was our first patient treated with this combined procedure. Only 1 week post-operative, it looked like this, which was really exciting. And 3 months later, visual acuity improved to 0.8. It looked pretty normal, except this cyst here, a little bit of thickening of the retina, juxtafoveal to the fovea. So we then decided to perform a prospective trial, and I show you some images of this trial. Meanwhile, we have treated 17 or 18 patients. All of these patients had typical lamellar holes with LHAP. You can see here tissue loss here as well, and again here. And after surgery, only 3 months later, the OCT images showed, just look at this eye, it looks like if there would have never been any changes in the fovea. The visual acuity improved also. I have to admit that at that time, when it was two of us, we performed kind of also, we didn't have a strict protocol. So some of us performed ILM peeling, some not. Actually, I did the ILM peeling as well. But my colleague didn't do the ILM peeling in two cases. And these are actually the 2 cases I show you now, because 6 months later, we found that although after 3 months, there was a huge improvement of OCT. After 6 months and finally after 12 and 9 months, we saw that there was a recurrence of the lamellar hole structures. The visual acuity still stayed quite good. However, the interesting thing was that these 2 patients did not receive ILM peeling. And this is the reason now we recommend the following. If we have a lamellar hole with decrease in with a worsening of the symptoms, worsening of OCT, we recommend to perform a vitrectomy, peel the ERM, peel the ILM, and additionally also inject autologous platelets after having removed all the epiretinal tissue. So coming back to this slide, this left area stays the same. However, at the right, when you have a lamellar hole, we meanwhile have a new opportunity. We definitely have to go back, not have to do some research to a progressive trial, which has already been started to prove whether the thrombocytes are really better, really improve the results, and maybe lead to a complete recovery of lamellar holes as well. Thank you so much. This was my fourth part of the Vitroidan Interface diseases. I'm happy to answer your questions.
Thank you very much, Siegfried. There is a first question from our young colleague, and the question is, in your opinion, which should be the first macular surgery case? Which one you think is like for the startup the best?
The first macular surgery case would be a silicone removal with an retinal membrane on it. Then you can try, and there's only low risk of doing any additional harm, because in many cases of a retinal detachment, which acuity prognosis is not that good. So this is how I started. Even you can try to peel a little bit of ILM, just be gentle. Then you don't have to be afraid that you're doing surgery on a patient. You still would have the chance to get a visual acuity of 20/20. But and if this is going to be kind of the first cases you can practice, the other thing, of course, is retinal membranes, better than these cases like a lamellar hole, because there you really have to make sure that to remove all the ILM, which in these cases is quite more difficult. And the third step for me would be a macular hole. And interestingly, the macular hole, in macular hole cases, the ILM peels is easier to peel than in, for example, cases of diabetic retinopathy, which definitely is the most difficult one. The epiretinal tissue, and especially the ILM, is very attached, and it's very difficult to remove it. It even takes me much longer than a simple macular hole case.
Okay, thank you very much. I have a question, actually several questions, because this biological kind of treatment, I think, is the trend in any kind of ophthalmological subspecialties. Of course, that includes the retinal surgery as well. Is it the same platelet concentration for the case which you showed at the beginning and the case you showed for the partial hole, or like for the full thickness macular hole? And for the partial hole, do you use the same concentration of platelets, or you use different procedures?
Although actually this machine offers the opportunity to use different concentrations, I usually go for the high concentration. When I was discussing the macular hole surgery with the platelets, you have to know that platelets have been used for a long time already. But people used it not for special cases, but they used it just for simple cases. I use platelets in lamellar holes, and I use it in cases of persisting or large recurrent macular holes, where I, in the end of the surgery, after closing the hole by suction of the fluid in the macular hole by using a fluid needle, I finally inject additional autologous bladelets to even increase the chance of a hole closure. So to answer your question, I think a simple macular hole doesn't need autologous bladelets. We can use it kind of as a second hand in difficult cases to additionally cover the folia and increase the chance of a hole closure.
I would like also to comment that it looks absolutely fascinating for this partial macular hole when you add platelets, how the macula restores, because it looks much better than any transplantation of retina or anything that is made, for example, with iPS cells in Japan and so on. Do you have any secret explanation about the actual process that happens into this area?
To be honest, when I first saw this publication by Gonzalez, he actually published 3 cases. but only one of this case was of these three cases was a real lamellar hole, and that's like this can't be true. And this was actually the reason why we have to prove that this is not possible, just to let the people know that they shouldn't treat macular holes like with this procedure. And then we had the good luck that we found the machine which gave us the opportunity to get the platelets by ourselves. We don't need a blood bank, and it was really exciting because this looks like this looks like it would not have been the same eye, and yet to answer your question, the mechanism, I tried to answer it in my talk. Maybe it's the platelets, the growth factors stimulate the Miller cells, and they can kind of recover. And in combination with the attractive components, this leads to a complete recovery of the fovea, which actually means that we don't really have a loss of tissue. It only looks like, because otherwise, if there would be a loss of tissue, a complete recovery would not be possible, because the platelets themselves they dissolve kind of. The platelets themselves cannot change into retinal structure. So it must be. So we actually learned something about pathophysiology of the lamellar holes, and I believe there's no tissue loss, there's only tissue change.
Yeah, and this actually is confirmed by the case of your colleague, because when he did not take the internal limiting membrane, after that you have almost the same picture, which basically means that you have reorganization because of the internal limiting membrane fibrosis or whatsoever the process is there. So basically, the OCT is again not panacea, I believe, because we see something, we believe that we see exactly the histological structure, but what we exactly see, nobody really knows in absolute detail. And maybe it's really a question of reorganization for some of those diseases. So I think it's quite interesting. Okay, I do not see any more questions from the audience, and I think that was really fascinating, especially this rearrangement of the macula after surgery. It's really something which everybody dreams of, that we have a technique to restore, and for the future it's going to be even more important. So thank you very much for sharing this with us. I'm sure that this collaboration is not going to finish here. We are going to have more options for future collaborations in different ways and in different manner. So thank you again. Thank you for your time and for the fascinating talk. Thank you very much.
Thank you, Christine. It was a real great pleasure, and sunny greetings from Munich. Today it looks like the image of my slide. Have a good time. Happy Easter, everyone. See you all, guys.
Bye bye.